All right, well, it's 5 after the hour, so I think we'll go ahead and get started. Thanks everyone that's joined so far, and we anticipate others joining as the morning and day continues. For those that I haven't met before, my name is Dr. Jay Hami. I'm actually a pediatrician at Mayo Clinic in Rochester, Minnesota. I'm actually covering the newborn service in Austin, Minnesota, which isn't very far away, hence my scrubs. Hopefully I won't call the way throughout this. But I also serve on the board for Africa Partners Medical, and I've had the pleasure of being sort of the point person for coordinating continuing medical education conferences, both in person in Ghana for quite a few years now, and since the pandemic, some of these virtual sessions, of which we have a nice one planned for today. We had hoped to all been in Ghana together this past week. That's when our in-person 2020 conference was scheduled for, but pandemics change plans sometimes, so we're looking ahead to March 2022. We had planned to meet in 2020, then it got pushed to 2021, and now it's pushed to 2022. But we wanted to continue interactions and opportunities for some ongoing medical education. And I appreciate all the speakers that have agreed to participate today. They're all doing it on their own time, all volunteers. But each of them, because they have areas of interest and areas of expertise that they want to share with each of us. There are other members of the Africa Partner Medical Board that are on today. Some individuals that are speakers have participated in person meetings or several times in Ghana. Some have participated just with the virtuals, but we really are looking to have all that are interested in learning and all interested in teaching to continue to have opportunities to be involved. So throughout the 4 hours today, we've got several speakers, initially about 30-minute time slots on the various different topics, starting with Dr. Ken Kim. And then we'll have a short break. And then when we reconvene, we'll have some breakout sessions, and we'll make a breakout room for those that identify and want to be part of the nurses breakout session, and those want to be the physicians breakout session. Feel free to use the chat function throughout the morning if you have questions, either that you real time or things that you want to communicate, and we're hope to have some good periods of interaction as well. With that, I'm going to turn it over to our first speaker. I'll allow her to introduce herself and her topic for today, and thanks everybody for being with us.
Okay, thank you. Let me share my screen. I'm Dr. Jemima Kankam, product of Ghana Medical School, proud class of 1975. I'm a psychiatrist, did my training at University of Maryland in Baltimore here. And I've been in practice for, sorry, have a double. I'm also technically in the 10th century. So let me. Okay, all right. Thanks, Jay got me through this morning. So I'm a psychiatrist, and I'm also a patient advocate, and I'm also passionate about mental health awareness, because mental health, it's 2021, and in some ways, we haven't changed much. Mental health is still misunderstood. This year in particular, mental health has been in the news, not just for the pandemic. We heard about it in the Olympics. It's all over the place, but still, as much as it is impairing the quality of life of people, there's still very little adequate training. I think that's the main thing in terms of its relevance here. In many of the disciplines, despite the advances in technology, you still have, practice training. It's not just the textbook. You see many patients and you go over and over. So by the time that you finish and you are out practicing, you're not just looking at your textbook, you have it in your head. But it's not so with mental health. And where I am, I still have residents who on their own want to come for like 2 weeks because they come out and they see that really their training is not adequate. There wasn't enough time relegated it. So whenever I have the opportunity, I just want to do what I can to influence. WHO tells us 1 in 4 of us are going to have some kind of mental health disorder. So that means that those who are sitting in your practices, no matter what general practice, the specialties, some of them have, in addition to what you're treating them for, they have mental health, especially the common ones that we all hear, depression, anxiety, have it, and it impacts their ability, to take care of themselves. So it is very important. Most of our referrals, I would say a majority, comes from general practice and other specialties. So I hope that something that you hear today can make an impact. So I'm not going to give you just the book, the textbook. You're going to see lots and lots of diagrams, because the other thing is the onset of most of the common mental illnesses are by age 14, which means high school, middle school. So we need to be able to not just treat people, we need to be able to educate them in their level language. So whatever we hear, we should be able to say it in layman's language. And that's also what is sometimes lacking. Some of my patients come and they can tell me, explain all the other medical illnesses that they are being treated for. And when it comes to their mental health illness, it falls apart. So thank you for coming. So the topic is incorporating mental health, the impact of COVID-19. And it's not just about COVID-19. It needed to be part of it. There's no health without mental health. We already know that. Okay. Okay, why is it not moving? Okay. So those of us, and I don't know about Ghana. It's been a while since I practiced in Ghana, but I know those of us here know that no matter who you see or what a patient presents, you still have to do a review of systems, of the other systems, not just what they present with. And how extensive you review other systems may determine how much you get, how much you paid, because that can determine whether you were considered to have done an extensive evaluation or a limited one. And so anybody get their notes, their records, will see the review of the systems, and mental health is part of it. But it's interesting to see what goes under there. So I just put there to remind us that it's still part of it on paper. Okay, so I just reminded, we all know that this is what you all do, but I just put here to know that we are part of the system. Your cardiovascular and respiratory and all the other systems, we belong in here. So mental health, I tell people, is part of, we say mental health, but we mean mental health system. And so everybody has it. And in the brain, there are 2 systems that are relevant here. The intellectual system, everybody knows about it. We know that that's what a child, develops the capacity to acquire knowledge. And that's almost predetermined. When a child, they can talk, point, say words, and all parents know that. And if it doesn't happen at a certain time, they know to go to the pediatrician. It's the mental health system, which is an issue. And the difference between the two is that the intellectual health system is acquiring knowledge, okay? But we also know that knowledge alone will not help you survive and thrive in life. And I use this young Wiz here, which I'm sure those from Ghana know him, Owura Baby. He's on YouTube. He probably has more facts than all of us combined here, because he's one of those where the capacity for this knowledge is on the extreme end, and he knows the Bible. He knows, just put Ghana, I put Ghana little words, and he comes up. But I don't think that his parents are going to leave him with all his facts, to leave him to cross the street or leave him near a fire. Why? Because as much as he knows knowledge, he has knowledge, knowledge alone can't get us far. What will keep him safe? He has to be able to give meaning and value to those facts. And that's what the mental health system is. It is the system that associates the facts that we get from sight, from our vision, what we hear, what we see in childhood, and that is not so predetermined because a child hasn't got much experience in life to know this is danger, this is desirable. So it's very much influenced by the adults around us. And that also gives us the opportunity to remember how we influence our children, because that's going to they're going to associate. So that's why I put Owura Baby here. And we all know some people who are very knowledgeable, not necessarily wise, and wise are not knowledgeable, and the two are not the same. Sometimes you hear people surprised that, oh, this person has a mental health disorder, but they are professor, or they are so rich, they are this, they are knowledgeable, but they are two different tracks. So the mental health system, like I said, excuse me, what is its role? The role is to it's a decision-making system, assessment and decision-making system. And at the end, it's to keep us content. Content doesn't mean things don't happen, but you're still content. Things happen in the world. It knocks you down, but you still keeps you centered. That's what helps us adjust to everyday stressful changes. And we'll come to that, because everyday stress is not what we have experienced in the last 18 months. Everyday stress, the equivalent is like in physical, if we go to physical life, when we walk, we're going up and down the stairs, we're walking along, you are stressing the muscles, and the muscles, we are building the muscles by stressing them. But there's a different stress if you suddenly fall in a ditch, in a hole. That impact is not normal stress that builds your muscle. That impact is a trauma that can do harm. And that's the equivalent. What happened in the past 18 months is not the everyday stress that promotes health. The other thing is, it also helps us relate to other human beings in appropriate context. And overall, it facilitates the use of our knowledge, to function and contribute to society. Whether we are in school, we're working, you function. So these are when our mental health fails. These are some of the impact that leads people eventually to go for help, or somebody encourages them or forces them to go for help. Okay, so how does that happen? How does it go from how it develops? Okay, so the knowledge, information we have, the experience a child is getting, they all associated with like 4 value systems. And this next, put this here, okay. And there are 4 value systems that keep, it's almost like it keep building up by as you get experience. You know, one is associated with things that are dangerous to be feared, okay? And then things that are associated with like a challenge to our integrity, which is resentful and to be fought, and not to run away from it, but to be indignant about, okay? And those situations and things that associate with being optimistic, hope, desirable. And the opposite of that, being pessimistic, associated with guilt and shame. And it's like, as we're growing up and we're experiencing things, and the, like I said, influence of the adults in our life, it's filling these that I call lenses, okay? And from this goes, you know, the thoughts associated with each, like fear, catastrophic thinking, you know, usually of a future outcome. It will never, things will never go well. Or there's actually the fear of many things, fear of being not accepted, fear of animals. This is a whole category of fear. And the resentments can be described here. The mind is suspicious. Those are the kind of thoughts that are associated with this, suspicious of the intent of someone else. And it's challenging, and it's, you know, optimism, the hope, which gives courage to take risk and confidence. And these are all normal. These are normal, everyone, you know. And the pessimistic, again, it's what gives the shame. And we need each one of that. All these are necessary for normal function. Okay, so these are like filters. I stole this from somebody's advertisement because it really, you know, reflects it. So it's like these 4 value systems become our lenses, but not in our eyes, but in our brain. So so whatever we take in, you know, hearing, vision, touch, all the senses, it's filtered through another level in our brain. So it's not what we see or hear, but it's what our brain is seeing. If our brain is, and the one that I usually use as an example, coming from my background, you know, you are back home, a snake is to be feared. There's nothing like oh, this is a garden snake, this is a pet. You hear snake and you have lived your life associating it with fear, because snake is going to kill you. So it becomes almost like a habit, a mental habit. And so I call it the mind filters. And we all have, every one of us, by the time that you're an adult, you know your system, okay? Enough that if it changes, you know there's a change. And I tell the story of my daughter who came running home and said, "Oh, mommy, I see a snake." And she was saying garden snake. All I heard was snake. And I went into my Ghana mode. It's going to kill me. Let's go for some men from next door neighbor. And she's looking like me. What's she talking about? So where I come from, snake, you fear its danger. So how does it work? So this is still the same filters, okay? The filters: optimism, disgust, indignant, fear, and pessimism. So when there's a situation, depending on what it's been associated, and I will use my example of the snake, okay? Where the snake is green, the color is beautiful. No, what is predominant? will be the fear, okay? But for the normal working of the mental health system, all of them collaborate. And this is how I explain to the children. They all talk it the same, they look at it the same, okay? So is there something that's optimistic about it? Is there something that it's hopeful about it? They all work together. And when we come to the breakdown of the mental health system, it's when they are one level, not collaborating with each other, okay? So this assesses because its role is to keep us safe. So in the case of the snake, they all assess, but fear is the overriding one, okay? And these are all in our thoughts. Nobody can read our thoughts. They're expressed in feelings, and each one has its corresponding feeling. And in mental health, sometimes the perception is, it's all about feelings. No, feelings are just expression of what these thoughts have assessed the situation to be. And so we have the corresponding, the happy, anger, anxious, and sad. What is very relevant, which is forgotten about, especially with clinicians, our colleagues, is it is also expressed physically. Physically, I'm not sure whether you can say physically, internally, which is usually the small muscles internally, palpitation, sweating, pupil dilatation, our breathing, the flow of saliva, all that is also part of the expression of some of these. And then the bigger physical expressions like the body, our voice, muscle movement, our facial expression, sleeping habit, eating the things are habit, and then overall movement. What is important about this to know that seeing this, you can't read somebody's, you can't see my mental health because you can't read my mind. You can't even know my feelings. And even some of these physical, majority of it, you can't know. So it's people say, oh, I don't think he's depressed. Look at how they are. If they are depressed, they won't be dressed up. They won't be doing this. No, you don't know. You can't see anybody's mental health. Okay. And even, I say that even the sleep, if you are sleeping with someone in a bed, unless you kicking them all night, they will know that you didn't sleep. So that's the first thing, because even in clinical practice, there is still the judgment of you don't look this way or you don't sound this way. We can only do this by asking, exploring. So that is the point of this, okay? So anytime that, and how I hope that you come across this, I'm going to show this over and over, that even while you've seen the person who came to you with blood pressure problem or breathing problem, you can still say, I'm not sleeping. Or what's going on in your mind? Has there been any changes in the way you've been thinking these days? Is your feeling different while you're still doing your, putting your stethoscope and all that, so that it becomes a habit that you exploring thoughts, feelings, and actions. So if you take nothing, just this picture, I know that you will do a lot of good with them. Okay, so if you didn't see it, I just went over the internal, the external expressions. And sleep is one big one. Just yesterday, I had a patient who was frustrated. I can't sleep, I need something. And expected me quickly get something, for you to sleep. And I, explored while you're not sleeping, what's going on in your mind, Well, I wasn't thinking, I wasn't worrying about anything. So I know it's not anxiety, it's not worrying, okay? And I wasn't, during the day, I'm active, I'm doing things, I have too many things to do, I know then it wasn't that she wasn't sad. So we eliminate by just asking, exploring, and you can do that. I know that you are in your busy practices. So I want to stress that it can be done while you're doing something else, just like we can be discussing, having a discussion, having conversation with someone, and you can learn a lot. And in their case, they weren't worrying, it's just their brain was full of ideas, which will come to what it was. And they didn't need a sleep medication, they need a different thing. I talked about the role of stress, just like, you stretch anything to some limit, there's a rebound. You stretch it beyond limits like we have done psychologically in the past year and a half, there's a risk of snapping. Okay, I'm already ahead of myself. Normal mental health, the lenses collaborate. The other thing that is also important in the normal function is our thoughts have to be organized. And we all know, because for the most part, our system works. So we know the number of thoughts in our mind at a given time. If it seems slow, we know that my thoughts are slow. I don't have so many thoughts. If it seems that there are too many thoughts, we know it. Nobody knows that. But you being the clinician, you can know that, and you need to find out, are your thoughts, do you feel like your thoughts, too many things on your mind now? And those too many things, the quality of them is important. Too many things can be all worries or just ideas, and they point to different things. And are they orderly, or are they jumping from one thing to another? Again, you can, once you have it in your mind, you can do all that while you're doing other things with the patient. And I find analogies in discussing with my patients. One came up with, it's like a car. Some cars, a car doesn't, 3 cars don't get to where they're going. One probably was slow. One was fast, but they were zigzagging. One was, rubbernecking and looking at all problems. So these are the kind of analogies in our own mind that we can then use to help the patients. So we talked about the normal, but every system fails sometimes. And why do they fail? No different from all the ones that you all treat. Most of the mental illnesses are chronic illnesses. And chronic illnesses, it's a combination of genetics, which also means that is there family history when it comes to mental illnesses? Even in a developed country like America, people are still not diagnosed. So just asking, waiting to hear the name of an illness is it's not successful. But you hear people describe, oh, my dad, sometimes they will be in the room all by themselves, or sometimes they just switch, or sometimes they are so afraid. So the description can tell you, and then you have a high index of suspicion if you've seen somebody and they tell you that, like we do in the others. I've talked about stress. So this is where the last year and a half comes in. A system wants a stress that is graduated stress, that is not so unexpected that the consequences. What we went through in the past year, whether the infection itself, where you're watching TV and seeing, you're seeing cast and bodies, mass graves, things that it's not the normal thing that you see. So it's overloading the system. Even the preventive measures, it's not normal to slap something on your face, but it was still, so everything about it, being quarantined, there was a lot of stress because usually families, each one is, in 24 hours, families are not cooked up under the same roof. Someone is in school, someone goes to do something. Suddenly, family members, couples who love each other, didn't know what to do each other because they haven't lived under the same roof for 24 hours straight. So there was a lot of things that it was more trauma than stress. And we all know how it became political. So again, added to it, the trauma of the past year has increased the risk of our mental health becoming an illnesses, especially in those who also have genetic risk. So it's layers, and then lifestyle, substance. We also hear that substance like alcohol, different substance, and different also medical illness can contribute to it. Now, let me just say quickly, issue of substance, especially where we come from, it's where I come from originally. It's easy to say, oh, they got this way because they were smoking weed or they were smoking this. What we know is because many people go through undiagnosed, sometimes this is self-medication. This is the best most people can do. And there are some people, some patients that I say, at the time that you were using, you would have been dead or somebody would be dead if you didn't. That was the best. But at some point, it's no longer. So we need to look beyond just, oh, if only if you stop. What was it helping them that now we can help them with? So I've talked about the impact of COVID in terms of even the scientists didn't know what to do. So it's scary for everybody. I want to get to question and answers or discussions. So back to, so this is now, we're not going to use this. We talked about this being the health, normal health. So what happens when it breaks down? And I'm going to focus on the illnesses, the common ones, the mood, what we call mood illnesses, depression, and anxiety. So one of the ways, instead of the collaboration, each of this can become the predominant one, almost like silencing. And bear with me if I seem to be saying it in simple words, but I'm used to educating the young ones, the non-clinicians. They are my partners in my advocacy. So that's how I describe it. So say if it is the pessimism, it's almost like in those filters, these filters are unseen. Everything is seen through the filter of shame, regret, no hope, okay? And this is where in the normal, before it goes too far, this setting, optimism, you hear the words of hope, you know, so that it's not gone too far. Where it's abnormal, it is rigidly just one. And so it goes on every day. So our criteria, it's almost all day, every day, everything is hopeless, hopeless, hopeless. And the behavior component of it, the physical, that's also learned. You know, if all around you, you are sad and you hear people screaming, crying, that's what you pick up. You know, I always say here in the hospitals, you don't see people come and wail in the hospital because that's not what happens. In Ghana, you're likely to see that. So this is also influenced by the culture around you. So this is, and when this continues, persists for a while, that's where the mind eventually feels that there's no way out. That's where the suicide thoughts come in. And it doesn't go from one day and the next day someone is suicidal. It starts with what we call death wishes. I wish this will end. And it continues, persists. And when people don't understand, my analogy is in a burning fire, you know, burning house, you've seen people jump to their death. Now, what they were seeing, the fire that was chasing them seemed to outweigh everything. There was no room to to think if I jump this, they are running. And that's what people, if you ask, in the past, we didn't ask. Now, anybody who is under a state of depression, we know that thought can come to them. So ask, are you having thoughts that life is not worth living? It's your mind producing, thoughts of what to do. And then we look for protective, protective factors, what will make you, some people, my children, my religion, whatever it is, we're letting them hope. But we also say, when your mind can hold on to that hope, that's when you get yourself in the emergency room, talk to somebody, do something, okay? So each of this, so this is a depression. So we say you are in an episode of depression if you are persistently seeing things through the pessimism lens. It is lasting like weeks, which is different from being sad about something, and it's affecting your everyday function, okay? We say if it lasts like weeks, you are in an episode of depression, okay? Same thing here. If this is the predominant, and these two kind of associate with each other, people who experience depression, or if you experience depression, sometimes anxiety, it's almost like it pulls it in. Now, these two are the ones that are least understood, because they also you can be in an episode where everything seems to be challenging. Somebody says something, how dare you? That's how your mind is interpreting, how dare you? What do you mean? And you get angry. And again, these are all changes from your usual, okay? And however you respond to anger is what you see. Same thing with this. Even though in normal, it's hope. When you have hope, courage, risk-taking without caution, it's still not healthy. So there are times when if one is in this episode, everything, there's no risk to anything. Someone told me, it's a teacher, they jumped from some high thing. They didn't want to die. The mind doesn't see caution. So all these have to work together for us to function. And each of them separately, it is an episode, just like we can have an episode of cough and other things. Now, the easiest is the anxiety, each episode of anxiety, if it's severe enough, the physical symptom of anxiety is what makes people run to the emergency room. I think I'm having a heart attack. My chest is hurting. You have a panic attack. So it can be diagnosed easily. You're having an anxiety attack after they've done so many EKGs. But ordinarily, most people with anxiety illnesses don't go for treatment. Their quality of life is impaired, but they don't know that it's an illness and they just avoid things. The depression episode, and I want to stress episode, a bout of depression, it's the impact that lets people go to get treatment, or most of the time sitting with their primary general practitioner or specialty care. I can't sleep. My energy is low. These are the physical symptoms. And what we are stressing is, please, while you ruling out all the high power things, just also consider, could it also be a mental health problem, by asking, okay? Like I said, majority of our referrals come from the general practice that would have been treating for a while until one day seems that it doesn't, it's not going where it should. The reason is this: we don't treat episodes. you don't treat an episode of cough. You look for the illness that it's associated with and treat it. So I'm going to focus the rest of time because the anxiety, like I said, it's easy for the clinician to determine that. Depression, when you have a depressive episode, somebody comes and you've correctly diagnosed that, oh, you are in a depression. To determine what the illness is, you also have to ask whether they have ever in their lives had an episode of any of these two, the optimism, or the disgust. And the easy way to ask is, has there been any period of their life where you get more angry than your usual, or people tell you that you seem to be more angry and everything? Sometimes I'll say, what will somebody who knows you say? Oh yes, I get into these modes, or sometimes my mood swing. You explore, because if you don't, and we get to that, the easiest thing, at least in the States, it is very easy to get hold of any antidepressant and treat, okay? In Ghana, I know it's coming now. I know that it's easier now to get antidepressants. So that's why it's important to know that an episode of depression is not the illness. Okay, so I'm going to go ahead. I want to get, okay. So we have the symptoms, you have the physical, the thoughts, and you get these episodes. So episodes, you're not going to treat episodes. Depression has its anxiety. The two, joy and anger, those episodes, we call them mania. So we have 3 episodes in mood: depression, anxiety, and mania, okay? And if they present with any of these two, most people are not going to present with anger or joy because it's not distressing. So why would I go to a doctor because I get angry all the time? So people don't come here. They are in jail, they are losing their jobs, they are in relationship problem, they are impulsive, all that. You know, this is unfortunately seen in social, you did something wrong terms. These come to us and we need to ask. And if you ask, you will get it, you'll be told. So from episode, we want to find out what is the illness to treat. Okay, so anxiety, like I said, anxiety episode has many disorders. And I won't spend the time on that because, you know, you're not likely. How you know is, what is it you fear? And depending on what the fear is determined. It's everything be scary. Everything seems like it's going to, oh my God, that's generalized anxiety. We have obsessive compulsive disorder. The mind, this person will say, it doesn't make sense, but I have this in a loop in my mind. The religious person is being blasphemous in their mind, and they are very distressed about it. And then in turn, they do ritualistic, you know, behaviors. Social anxiety disorder, which is, you know, the fear that you'll be ridiculed. It starts in childhood. These are children sitting in class and they will never raise their hand up. It's disabling. We have post-traumatic stress disorder. In the past year, there are many people who have been at risk of it. There has to be a trauma, okay? And in panic disorder, where you have the attacks, you are not worried about anything. The attacks come and you are afraid of getting another attack. So these are anxiety episodes, which I want to spend the time on the depression, okay? So you have an episode of depression you've done. How do you know what to treat? Like I said, you ask the person, have they ever, they don't know what mania is, so you're not asking them, have you had mania? Have you ever had a period in your life where it's the joy line or the anger line? If it is yes, I have had ever, then that illness is called bipolar depression. If they say, no, I have never had it, then it's likely to be major depressive disorder. Why is it important? The treatment, especially medication treatment for these two, are as different as treating hypoglycemia, present hypoglycemia, making sure that the person is diabetic or is a non-diabetic. And you know that the treatment for the two are different. Unfortunately, studies after studies show that it continues to be misdiagnosis, continues to be the problem with depression. Because we join in say depression as if it's one thing. And giving a depression medicine to somebody who has bipolar depression is like giving sugar to a diabetic who comes hypoglycemic, and you just say, okay, get your sugar, and every time just keep taking your sugar, you know what will happen. So this is where I really want to stress, because soon in Ghana, there aren't enough, we keep, you know, in the last 4 years, I've been involved with the advocacy in Ghana. So we keep telling people, go for help, go for help. But getting bad help is worse than not getting help at all. So I know that the primary care, general care in Ghana is going to start seeing and treating, hopefully. There's not enough psychiatrists to treat everybody, and you can do it. So this shows it. Say, example, say this person comes to you and they have you've done asked, and you say, oh yeah, you're in an episode of depression. You ask, they've never had an episode of the mania, the anger, or the joy. So this illness you're treating an episode in a major depressive disorder. So any of the antidepressants, the Prozac, all of them are equally efficacious. One will help this person. You don't see this person again, and you see them at some point here. And you say, oh, okay, Kojo, you back. How are you doing? Haven't been doing well, you know, I'm down again. Without asking, how have you been in between? If you don't explore this, this is now a different illness. This illness is not the same as this illness, because in between they have experienced a mania. And if we ask, they don't know to tell us. So this illness will not need just a depression medicine. You need a mood regulator, a different, I'm not going to focus on medications because they come out, different medications come out, and what's important is to know what group to use. That in bipolar depression, you need a regulator, just like in your diabetic, you're still going to need your anti-diabetic medication. Same thing here, you know. So, and unfortunately what happens is because of it's easy, it doesn't take long to determine somebody has depression, because they are in pain. So they are telling you all of it, you know, just like you're in pain. I don't feel good, and this. So this is where the work is. So in between, have you been angry more than your usual? Have your thoughts been going fast as these and this what? So that's the whole point of this, and I can't stress it enough that this happens all the time. So I just had.
Kim, sorry to interrupt. This is such wonderful information. We're just getting quite a bit behind schedule. So
I'm sorry.
Yeah,
this is my last slide.
Such good information. Yeah, why don't we'll use this, and we'll maybe have people send you Q&A through the chat if they have any when we start the next presentation.
Okay. So I've actually, this is the end of the slide case. I've incorporated even that case in. So if you have so we won't have time for questions. Are we going to have time?
Well, I think we'll have to hold off on them so we can kind of keep moving with this.
Okay.
Thank you.
Thank you for all listening. I hope you got something that will help. And if you did, you can give my email, address, and I can answer any questions.
I think that's wonderful. And if you don't mind sending me your slides, I can certainly distribute those as well.
Yes. Okay.
Well, I want to thank you so much for getting us off to such a great start this morning with such an important topic and review. And Dr. Kim, mental health is so important. And I know you focused on the patients, but I'm sure if we'd have you back to talk about the healthcare, mental health of the providers, you'd have just as much important to say. And I know you have some other commitments, so thanks for being with us this morning.
Okay, thank you.
We're going to transition to Dr. Melinda Harris, who is a veteran of many both in-person and virtual Africa Partners medical conferences, a neonatologist, and I'll let her jump right in. Thanks.
Thanks, Jay. Good morning, everyone. I'm happy to be here to share a neonatal topic. Many of you requested a talk about neonatal hypoglycemia. And so I've given a brief overview of it, but there's plenty of room for questions. If there's anything that I don't discuss or that you want discussed more in further detail, I'll try my best to answer it. But I'm not an endocrinologist, I'm a neonatologist. So we'll just have to see if I can answer everything. Hold on just a second, there we go. Okay, make this smaller. Okay. So there's just like everything else in neonatology, when the fetus transitions to an infant, there are so many physiologic changes that happen. And this happens with glucose as well and how the body metabolizes that. And so there is a normal nadir in blood glucose concentration, and that is typically no lower than 2.2 millimoles per liter. I have provided, I hope that these numbers transition right because I operate off of milligrams per deciliter, but I've tried my best to make sure that these are accurate for different units. So this occurs within 2 hours of birth, and it just results from what you would expect. There's a continuous supply of sugar coming from mom's umbilical cord, and then suddenly that's clamped off and it's not there, and suddenly the baby has to make its own blood sugar, as well as any other components of its metabolism. And so the baby switches from this continuous supply of ready-made nutrients coming straight from that umbilical cord, and it goes to having to eat to be able to get those nutrients. And it's not eating continuously for the most part. It's eating intermittently. So the body has to find a way to store those supplies away so that then it doesn't use up those components immediately upon getting them. During that first 8 to 12 hours or so, there's also some hepatic glycogenolysis. And so there's glycogen already stored up in the liver fetally. And the neonate starts to use that supply, given the first few hours in which it's getting a lot less to eat, particularly those breastfeeding babies. The blood glucose, or BG as I've abbreviated it in this presentation, then stabilizes between 2.5 to 4.4 millimoles per liter, or 45 to 80 milligrams per deciliter, for the first 48 hours, and then continues to rise thereafter. For some babies, that's a 24-hour period of time, and then they have essentially a normal blood sugar. And then there's other babies that kind of dwindle in this 45 to 80 range for those 2 days, but then they should continue to go up. The problem occurs in having to recognize when is sugar too low, because for people who practice primarily adult medicine, these are very low blood sugar values that we're talking about for an adult to have. And so for babies, we have to decide what is too low. And so neonatal hypoglycemia happens, as you would expect, when there's not enough production for the amount of utilization. And so there's a variety of reasons behind that where that can happen. You can have too little glucose, and that happens in babies that are born prematurely and haven't had the time fetally to really store up all of that hepatic glycogen, or to have gotten enough additional fat layers to be able to metabolize fat as well. And that also happens in babies that have fetal growth restriction. There can also be inborn errors of metabolism and endocrine disorders such as adrenal insufficiency or growth hormone deficiency. Moms who take beta blockers can have babies that have hypoglycemia. Babies who are hypothermic and they just use up their stores very quickly. And then babies that have liver dysfunction can have impaired production of glucose. And then there are some babies that use more glucose. Like I said, the hypothermia kind of goes into both categories, but also the biggest reason we see here is hyperinsulinism. And this may or may not be the case in Ghana as well, but we have a huge number of diabetic mothers here in the US, especially in the South where I live. And so infant of diabetic mothers is the most common reason we have and that I see in my practice for neonatal hypoglycemia. And those babies can just have huge numbers, huge levels of insulin if you check it not too long after they're born. Fetal growth restriction, also those babies, again, don't have a lot of fat, don't have a lot of stores, are using more energy to stay warm. And so they can have more use of glucose and then become hypoglycemic. Beckwith Wiedemann is one of the most common genetic disorders we see persistent hypoglycemia with. Perinatal asphyxia, so a baby that's gone through a birth trauma. Those babies use a lot of sugar there in the beginning as they're being resuscitated. And then maternal treatment with glucose or sulfonylureas are other reasons that pairs into this hyperinsulinism. Polycythemia, so just the more red blood cells in the baby's body, there can be more glucose use. Heart failure, again, from working hard. Perinatal asphyxia, again, very similar to what I said before. It kind of all goes together, this birth trauma creating this hyperinsulinism picture, as well as the utilization of it just from the trauma itself. And then sepsis. So what's frustrating about neonatal hypoglycemia is that unlike adults, babies are typically asymptomatic. And so adults, typically it's very clear when an adult has hypoglycemia and they can express that to you, but babies do not share that information with us very readily. And so the symptoms we see, if we see any, are typically reflective of glucose deprivation. So things that you would expect to see and you may see in adults. Jittery, tremors, sweating. I don't really ever see sweating that often, but it is listed typically. Irritability, babies are tachypnic. Tachypnia is actually a really common symptom that I see with hypoglycemia. Those babies can be pale. They can have apnea and bradycardia. That's more common in the premature babies that are hypoglycemic as well, and hypothermia. They can also not eat well, have a weak cry. And then if it really progresses, they can develop hypotonia, more lethargy, and seizure activity. I've never seen a baby that's had seizures from hypoglycemia. It's very uncommon, but it's definitely possible. And again, these symptoms are a little nonspecific to some degree. This list of symptoms you can also see for a septic baby. You can also see it with a baby that has congenital heart disease. So unfortunately, a lot of times it's mainly the history that helps inform you to this. So when I talk about the history, I think this is one of the most important things to recognize because so many babies are asymptomatic. It's really important to know which babies we should be screening. And so clearly babies who are symptomatic, babies who are jittery, babies that you just don't know exactly why they're having that symptom. It's real easy to get a blood glucose. So that is one of your first steps that you should do. Preterm babies, those born less than 37 weeks, and post-term babies, those born greater than 42 weeks. We don't see many of the post-term, but the preterm hypoglycemia is very common in. Large for gestational age, so when we look at our growth chart, those babies who are greater than 90th percentile for weight. Fetal growth restriction or small for gestational age. Infants of diabetic mothers, really common. Babies who have had birth trauma, so they may have had non-reassuring fetal heart status prior to delivery. They may have required resuscitation. We screen any baby that requires resuscitation at birth. And then maternal use of beta-adrenergic or oral hypoglycemic drugs. And then if we're admitting the baby to the ICU for any reason, we are screening their blood sugar. Okay, so how are we screening? We screen via capillary or most often capillary using a bedside glucometer. We do send blood sugars to the lab occasionally and use a plasma sample, but that takes a really long time for us. So we prefer to do capillary screening, and the picture is reflective of what we're typically doing. All at-risk infants should be screened after their first feed. So what you're wanting to do is get that baby a bottle or to breast as soon as possible after delivery, and then check a blood sugar after that. If for whatever reason though, you're having to delay feeds, mom is under general anesthesia, or baby needs some resuscitation, then you should definitely check a blood sugar within the first 90 minutes. I would say if you're having to resuscitate a baby, it really should be sooner than that. It really should be closer to 30 minutes. And then you're going to continue to screen by testing prior to each feed. So every 3 hours, 2 to 3 hours, sometimes breastfed babies eat a little bit more frequently, of course, and do that for at least 12 to 24 hours. And that's dependent on the risk factor. The AAP has a great guideline for this that really delineates how long you should screen for each risk factor. Most of them are for 24 hours, however. And then you don't, the key part of that though, and I think it's a part that a lot of people here really seem to forget about, is that you don't discontinue it just because the time is met. You discontinue it when the time is met and you've had 3 blood sugars that have been adequate. And if it's an infant less than 48, well, in either way, but then the adequacy is dependent on how old the baby is, but at least 3 blood sugars in a row that have been adequate. All 3 must be sugars before a feed. And so you can see here that if your baby is less than 48 hours old, you want the blood sugar to be between 2.5 and 2.8, or if it's greater than 48 hours old, it really should be greater than 3.3. And that's where some of this is a bit frustrating. We don't have great studies to back up these numbers. These are a little bit of guesses. There's not a great way to do a trial relating to this, but this is where experts, especially kind of those experts from the American Academy of Pediatrics and the Pediatric Endocrine Society, really to at times agree and at times disagree, but these numbers are where you're most likely to avoid neurologic damage from persistent hypoglycemia. And so let's move on to management. The goal in the management of neonatal hypoglycemia is to treat only those who need treatment and avoid unnecessary interventions. And so we want to treat babies that actually are at risk for having neurologic damage, because some of our interventions can make it more difficult for babies to have, for moms to exclusively breastfeed. And so we want to make sure that we're treating only the babies that need it, because we don't like unnecessary interventions, of course. And then the challenge with that is what I was saying. We don't have a precise blood glucose value that we know risks neurologic impairment. We know that babies who are persistently less than below a certain number, below 2.8, are going to have damage if that goes on and on and on. But for days, but we don't know how many days, and we don't know how many of those blood sugars need to be low. So it's a very frustrating at times, especially for us neonatologists who are being asked these sort of questions from the newborn nursery, because we don't want to separate babies from their moms if we don't have to. And so there's definitely challenges with this. And any neonatologist would tell you the same, that this is an area of frustration to know exactly who we should be treating. Who we know we definitely need to treat are symptomatic. So we'll start with those. So babies who have symptoms of hypoglycemia absolutely should be treated, because those babies we have found are more likely to have neurologic sequelae. So if they're symptomatic, treat them. The AAP recommends you treat any symptomatic baby that's less than 2.2, but there is question out there. Like I said before, we have a little bit of lack of clarity if that should actually be higher in a symptomatic baby. So maybe we should be treating babies under 2.8. Definitely at 48 hours, we should be raising that level to 3.3, because it is not normal for a baby that's over 40 hours old to have a blood sugar that's less than 3.3 in most circumstances. And these are the babies that, rather than mess around with trying to feed them and get it done through feeds, we really should be going straight to doing IV fluids if you can. If you don't have that capability, of course, pushing the feeds is what you need to do. But if you have the capability, you really should be putting in an IV and starting glucose. And that starts with a bolus. So those babies should get 2 to 4 mLs per kilo of D10 over 10 to 15 minutes, and then start their D10 at a glucose infusion rate, or GIR, of about 5 milligrams per kilogram per minute. And for those of you who get annoyed with having to calculate GIRs, like I do, there are some great apps you can download where you can just enter in the IV fluids and the rate, and it gives you that GIR immediately. And then you're going to recheck your sugar 30 minutes after your IV infusion begins. And so see what your new sugar looks like then. And then you're going to titrate your GIR as needed to make sure that your sugar is staying above 2.8 to 3.3, dependent on hour of life. If the blood sugar still stays very low at that point, you may need to repeat your bolus in order to kind of get that threshold back up so that you can get that baby's blood sugar stable. You can continue to feed the baby during this as well. Most of these babies are still hungry. And so continuing to let them ad lib feed is still very reasonable, as long as you can maintain your IV access. Asymptomatic babies, it gets a little bit more complicated. And so I set up a chart here that kind of tells you what is generally accepted for what our values should be for where we accept babies' blood sugars to be. So a baby less than 4 hours of life, it's acceptable to continue working on feeds for that baby as long as the blood sugar is above 1.4 to 2.2. Somewhere, as long as it's above those numbers, then you can continue to work with feeds and not start IV fluids. Once they get to the 4 to 24 hour mark, then that's when we raise those threshold a little bit to 1.9 to 2.5. And then 24 to 48 hours, we really should be up to that 2.5 to 2.8 level. And again, at greater than 48 hours of life, our goal is for the baby really to be 3.3 or above, but it's acceptable in an asymptomatic baby for that blood sugar level to be 2.8 or above, with the goal being that we're trying to keep mom and baby together and protect the baby's brain. For asymptomatic babies, again, we should begin oral feeds as quickly as possible in at-risk infants. Those babies really should feed a breast or have a bottle within the first 30 minutes after delivery, quicker if possible. If the blood, and then once you check your post-feed blood sugar, if it measures low, you're going to feed the baby again and recheck within an hour. If subsequent blood sugars are low, you might consider using dextrose gel, which I have a picture of on the next page. I'm not sure how many of you all maybe already have that in your practice. If you do, definitely let me know, because I think that would be interesting information to have. We just incorporated this into our practice about 3 years ago now. And it has been a nice adjunct. The goal of it really in our practice is to avoid using formula and to stick with breast milk, because we have a hard time keeping moms exclusively breastfeeding at times here in the United States. And so we really use this as an adjunct to avoid formula and continue to boost mom's breast milk supply. And then practice varies at this point, but repeated low blood sugar measures prior to feeds or another blood sugar that's less than 1.4 really suggests the need to move on to IV treatment. So if you're still having if you have another low blood sugar at that age, it's really probably a good move to go on to IV fluid treatment so that we can get that blood sugar up out of the toilet. But then when you have these babies that have blood sugars that kind of dwindle in this, I'll go back. They dwindle kind of in this 1.9 to 2.5 range, and you're treating with gel or extra feeds, you have to kind of make a decision at some point to move on to IV fluids or a different type of treatment. And so what our general practice is that if a baby gets gel 3 times, then they get transferred to the NICU. And the vast majority of those babies have an IV started at that point. Now, if we get the baby and we bring it to the NICU and the blood sugar looks okay, we may wait and check another blood sugar before the next feed and see what that looks like, because sometimes that will be the blood sugar that will start to come up. And so sometimes that's kind of the make or break time, but that is typically what we do. And again, you want to continue to feed in addition to IV fluids, because at some point you're going to try to wean those IV fluids off. So we need to get the babies to be eating. If you get high enough on your IV fluid rate, you do have to start to worry about fluid overload. But I think typically by restricting feeds to some degree or increasing your dextrose concentration, if that's available, you can look at the volume and make sure you're not overloading the baby. This is what the dextrose gel we use looks like. It's lemon flavored. This all came from the adult world. Adults use dextrose gel, I guess, for a variety of reasons. I don't know. I've never practiced adult medicine, but for people who have hypoglycemia, I guess they carry this around and use it. And it comes in lemon or cherry flavor. We elected not to use the cherry flavor because it's red. And anytime babies throw up red stuff, people get real freaked out. So we chose to use the lemon flavor. And what you do is dry the baby's inside of the baby's mouth out with just a little gauze, and then squirt this onto your finger. We actually squirt it into a measurement container because your dose each time is going to be 200 milligrams per kilo. And I have to remember how many grams are in this. It's a lot more than that. So you have a little measurement container that you can use that measures out that dose. And so then you're going to pour that onto your finger and then rub it inside kind of the buccal membranes of the baby's mouth and get it good and absorbed in the baby's mouth. But the important part is to wipe out the mouth first so that it doesn't get too diluted and you don't end up having the baby kind of throw up everywhere. So when we talk about IV fluid management, I alluded to this a little bit earlier, but as babies have persistent hypoglycemia, you may need higher concentrations of dextrose. So for our purposes, we don't go above 12.5% dextrose in the peripheral IV, and we go up to 25% in a central line. So if you have the capability of putting in an umbilical line, you can give a bit higher of a dextrose concentration. And we use GIRs up to 12 to 14 milligrams per kilogram per minute. Specifically is looking at IV fluids only. We don't incorporate feeds into those calculations. It's very difficult to do that. We really just focus on the IV fluids for that. Once you get your blood glucoses stable, which hopefully will be quickly, but sometimes can take a while, especially on some of these real LGA hyperinsulinemic babies, you want to make sure you have 2 to 4 blood glucoses which are in range or above. So 2.8 or above for all the 2 to 4 pre-feeds. So AC blood sugars. You want to consider at that point beginning to wean your IV fluids. You're going to continue to check your blood glucose prior to your feeds, and then base your IV rate wean on what that level is. And there's no standardized way to do that. But for instance, I may wean by 2 mLs an hour on a blood sugar that's a lot on the higher side. I can't give that to you in millimoles, but for me, if I have a blood sugar that's 90 milligrams per deciliter or above, then I may wean by 2. And then if I have a blood sugar between 60 to 90, So that's 3.3 to the 90, again, that I don't know. I may just go down by 1. And then you can see how the baby responds. So if the next blood sugar still looks good, you may be able to increase your weaning. If the next blood sugar doesn't look good, then you may need to slow down how you're weaning. It also depends on how much dextrose is in your IV fluids. And so I think a good measure for this when you're weaning is to not, at the beginning at least, to not go down by more than one GIR, so 1 milligram per kilogram per minute. Slow your wean down to that. So whatever rate that ends up being for the IV fluids you're on. And then once you're off IV fluids, you need to continue to check those blood sugars and make sure they're going to stay stable, and check at least 3 more pre-feed blood sugars to make sure that your values are still stable. So persistent hypoglycemia is that is present beyond 48 hours of life, and that's even with treatment, because typically if you're still hypoglycemic at this point, you're probably on IV fluids. We expect that this physiologic transition shouldn't take any longer than 96 hours. And so if you are going beyond 96 hours, you really need to further work up this hypoglycemia. And so what we typically do is do an endocrine workup to some degree. I will start with an insulin level because the vast majority of the time that answers the question. Most of these babies have very high insulin levels, some extraordinarily high. I recently had a baby who had an insulin level of 200. And this baby was on GIR 14 plus all the other meds we can help with. And you may need to start adjunctive therapies at that point as well. A common drug we use that has pluses and minuses to it is diazoxide. You do have to worry with diazoxide because it can cause pulmonary hypertension and it can cause fluid overload. And so sometimes we'll start those babies on chlorothiazide as well with the diazoxide to help with the fluid overload. Hydrocortisone is another possibility. If you are doing your workup, you may include a cortisol level as well to evaluate for adrenal insufficiency. Other things you may want to look at too there are growth hormone, so insulin level, growth hormone. You may want to look at your lactate and that sort of thing to see if there's any other things that may clue you into why your baby's still hypoglycemic. And there's also possibly some use for glucagon as well. We don't use it in our practice, but there is some literature to suggest that that might be helpful as well. So my take home for these, 1, high-risk infants should be routinely screened for hypoglycemia at least 12 to 24 hours post-delivery. The biggest thing I can tell you is neonatal hypoglycemia is often asymptomatic. So if you have a baby well, you should be checking all at-risk babies. But then if you have another baby that doesn't necessarily have risk factors, but does something a little funny, check a sugar. It's really important because a lot of times it is because they're hypoglycemic. Persistence of hypoglycemia despite feedings requires IV fluid management. And we talked about at what time that would be really important to do. And then persistence of hypoglycemia beyond 96 hours really should be investigated further. It is helpful to have your endocrinologist weigh into this as well. They may have some additional blood work they may want you to get dependent on the situation. And that's all I'll have. I'm happy to take any questions. Or if there are not any, you're welcome to send me a chat message. I'll be on for about 10 or 15 more minutes, or Jay has my email address.
So, Melinda, I had a quick question for you about sort of the at-risk babies. Do you have it set up in your nursery where, is it a nurse-driven protocol, or how is that arranged?
Yeah, so it's a nurse-driven protocol. We actually, the AAP has a really nice algorithm that you can kind of just copy and use. And that's essentially what we've done. And so, but we oversee 5 newborn babies. And so if we were to try to keep up with every delivery, I mean, we have 7,000 newborns a year that we oversee. And so it would be very difficult for us to individually pick out which ones needed to be checked. And so what we typically do is just kind of have this list, and the nurses know what this list looks like. And if there's any questions, they call us. And then of course they call us if they have questions. Another portion of that protocol is the initiation of gel. So they can on their own start using gel, and just contact us with its use.
That sounds very similar to what we do, and it tends to work quite well.
It works great. We've seen, since we've started using the gel, we've had fewer transfers for sure. And we've been able to keep more moms and babies together.
Great. Any other questions or comments for Dr. Harris? Well, we always appreciate your consistent contributions, in particular, even on a child's birthday like today. So thanks for being with us. We appreciate it. And
you're welcome. I am going to go though and have a good child or birthday party. So
you should. All right. Thanks so much. All right. Our next speaker is Dr. Benjamin Achampong, who I think is on, and we'll start. There he is. So I'll let you take it away, Ben.
Thank you, Dr. Homi. Okay, I think I need to share my screen here. Can you see my screen?
Yeah, it looks great. Thank you.
Okay, so thank you for inviting me. First, I must say that it was a little bit of a difficult topic to kind of string together, because I wasn't so sure what exactly that I should be talking about in terms of the basics of cardiac imaging, because it could be like, do you want to understand the ultrasound phases of how images are generated, or probably what do we do with, or how do we do it? And so I think I'll probably try to kind of talk about a little bit of both, and also talk about some reporting. And for the most part, I think most of us are going to be consumers of the information that is generated from cardiac imaging. And so understanding what to expect and what to also put on your request goes a long way to kind of help with the communication between the ordering provider and the interpreting provider, so that it can lead to optimization of patient care. So these are some of the things that I'll be talking about. I know I have a limited time. I'll show some few cardiac pathologies, and also kind of review the windows or the views that we use to get cardiac images. I'll be limiting most of the talk to echocardiography, but I will mention some of the advanced cardiac imaging modalities that can also be used to get cardiac imaging. I have no conflict of interest to disclose. And so non-invasive cardiac imaging mostly refers to a combination of methods that can be used to obtain images that we use to assess the structure and function of the heart. And this is as opposed to invasive cardiac imaging, like doing cardiac catheterization, where you need catheters to be inserted into the heart to kind of get pressure and saturation data. Non-invasive tests are easier to perform, they are safe, and they provide valuable information about the heart. And so you don't need any special preparations for patients like you do for cardiac catheterization, or sometimes we even do for cardiac MRI and other things. But we need to also acknowledge that the advances in technology over the last decade has also brought in its wake a lot of non-invasive cardiac tests that we can now use to assess the heart. Now, with this availability of the test also comes with some responsibilities, that now there's always a talk about appropriate use criteria. it is important to understand that not all individuals benefit from non-invasive cardiac imaging. And sometimes we still have to rely on our history and physical examination to kind of make clinical decisions about the care for the patient. We need to be able to consider if only the information that will come from the cardiac imaging will influence subsequent management of the patient in terms of needing for treatment or no treatment, or whether the patient need additional procedures, or will this also help us to counsel the patient appropriately with regards to lifestyle intervention. So these are all some of the things that cardiac imaging can help us to answer. And so we need to be thinking about it before we order the test, what exactly that we think we will get from the additional imaging. Now, these are some of the cardiac imagings. Of course, we have electrocardiogram, which can be both a screening tool and diagnostic for rhythms, and also can lead us into getting additional imaging. Echocardiography is the most common one, and I'll show you more images of echocardiographic pathologies and normals today. Then, of course, we have the nuclear stress test, most often for perfusion and for myocardial infarction to kind of understand areas of defective perfusion. Then we have cardiac CT, which we do most often for coronary anatomy, but most often also in children, we do it for anatomy, for vascular anatomy, and sometimes even for functional assessment in patients who have, say, pacemakers and other things that are not MRI compatible. If we want to get more images, we can use a cardiac CT, and we do that a lot in centers across the US and including my center. And it is one of the things that I do, as well as cardiac MRI, which also provides us with some better definition of cardiac function, and sometimes also used to define myocardial properties that can help us understand things like myocarditis, cardiomyopathy, and a whole host of pathologies, about things that sometimes we cannot learn all of them through echocardiography. So honing in on echocardiography, we understand that it uses a sound wave. It is an ultrasound principle, and it's done by either sonographers or technicians and doctors who are cardiologists, and kind of allowing us to evaluate function of the heart and also of the heart valves, and sometimes about the vascular anatomy of the heart. No special preparation is required, and the test is most available. And for the most part, it is one of the most available cardiac imagings, apart from electrocardiography or ECG. Echocardiography is one of the most common tests that are performed to evaluate the heart. Now, I hope this will play, and I'll show you some 3D model of the heart, just to kind of zoom in into about how complex the heart is and understanding how we image the heart or generate images. I guess it will be loading. Do we see this one?
Right now, we're just still seeing your slide.
Oh, you're still seeing my slide? Okay, let me. Here. So now you see the 3D model heart. Is that correct?
Yes.
Okay. So this is the human heart, and this is how it kind of situated. And so you can understand that it's a very complex composite 4-dimensional structure that we want to use imaging to define all the aspects of the heart. So you can look from here, we see in the tricuspid valve is back here, and this is the right side of the heart with the blue discoloration. You have your pulmonary artery that sits in front here, and then we have the aorta that also kind of goes behind it. We have the left ventricle, and the left side of the heart also sits at the back here. and the whole angles that you can rotate the heart. And so when we are doing cardiac imaging, it becomes very important that we show all these angles of the heart to be able to understand exactly what we are trying to define. And so there are various views that we try to use to understand all the aspects of the heart, and especially to help us to answer the question of the ordering provider. So for example, this is one of the views that we will use to generate an image for the heart. And this is kind of what we call the parasternal long axis view. And this is essentially, it's like you are throwing your sunbeam or your ultrasound beam across how the heart sits in the chest, along the long axis of the chest. And it will show you some aspect of the heart, but not all the aspects of the heart. And that is why we look at the heart from various angles. Now, when we are looking at an echo, anything on the top part of our screen refers to an anterior structure. So the heart has a inferior superior relationship, there's anterior posterior relationship, there's a left and right orientation to the heart because it is a composite 4-dimensional structure. And so in this view, we do see that the right ventricle is the most anterior structure of the heart. And so when we are looking at the heart from the long axis, this is what we will see. So in this orientation, we see the right ventricle, we see the ventricular septum in this view. This is our left ventricle down here. It's a posterior structure. This is the mitral valve as it leads into its supporting structures. This is the left atrium here with the pulmonary veins that brings the oxygenated blood from the lungs. And this is the aorta, the left ventricular outflow tract with our aortic valve in this plane. And so this is the plane that we'll be able to see when we are looking at the heart from a parasternal long axis view. Now, we have to move our imaging or our sunbeam plane to see some of the other structures by moving either anterior or posterior, left or right, or inferior and superior orientation. Now we will also look at the heart in what we call the short axis view. And so this helps us to get cross-sectional cuts of the heart. And we can move this one all the way from the base of the heart to the apex of the heart. And this also helps us to kind of understand the squeeze of the heart. Is the function okay? And here we see the right ventricle will still be the anterior structure here. Our right-sided structures will be displayed to the left of our side. And the patient's left-sided structures will be displayed onto our right side. And the posterior structures are seen at the bottom of our screen. So this is the interventricular septum also in this plane, right ventricle here, left ventricle here, and we are just cutting through the middle of the heart to give us an idea about how the heart sits. Again, we will also look at the heart from what we call the apical view, just kind of like where we get our apical impulse, where we are doing our physical examination. We will put the probe there, and the probe will also give us a picture like we are cutting through all the chambers of the heart. So this is the right side of the heart. This is the left side of the heart, left ventricle, right ventricle. This is the tricuspid valve in this plane. This is the mitral valve in this plane. We have our left atrium, and then the right atrium is here. And then we see our interventricular septum here, and this is the interatrial septum. You also recognize that the tricuspid valve sits a little bit lower compared to the mitral valve, and this is a natural offset of the tricuspid valve from the mitral valve, and there is a distance to which it should offset. If there's too much offset, then you are getting into the realms of Epstein's anomaly, and so that is how we make that diagnosis. This is a subcostal view, and this is just one view that I'm showing you because you'll be moving and rotating your probe to get images. But this is important because the subcostal views are important in the diagnosis or evaluation of the atrial septum. So the atrial septum sits a little bit parallel when we are looking at the heart from the apex, and we will see a lot of dropouts. And so I've seen in other places that I've gone and worked, I've seen places where they have made diagnosis of atrial septal defect by looking at the heart from the apex because there's dropout. But the best way to diagnose atrial septal defects is to look at the atrial septum from the subcostal view, because in this view, your ultrasound beam is directly perpendicular to the atrial septum, and you are able to get good reflections of the sound waves and be able to define the atrial septum. So we look at the heart from a lot of angles. Now, this is the suprasternal notch view, and this is how we assess the aortic arch and to make diagnosis of coarctation of the aorta, to measure velocities. And so also from this view, if we do some maneuvers of our probe, we'll be able to see the pulmonary veins as they are coming into the left atrium. And it all helps us using all these views to kind of have a basic understanding of the structure, function, and vascular anatomy of the heart. Now, the important thing for most of us will be consumers, as consumers of cardiac imaging, will be how do we understand what is put in our report? And to me, that is very, very important, because when we order the test will make sense to us, and we should be able to use it to further patient care. And so both the ordering provider and the interpreting provider have a sole duty to make sure that the question for which the test was ordered is answered, and that there's a communication between the ordering provider and the interpreting provider for the information that needs to be conveyed. And these are some of the things that needs to be incorporated in the data that is generated from cardiac imaging. So for the requesting doctor, it is important that the biodata of the patient is incorporated in your request, because it helps us a lot. When I'm interpreting an echo for a newborn, the way I look at it may be different from when I'm interpreting, say, an echo for, say, an 18-year-old person, and whether the person have any cardiac history or have any symptoms that points to a cardiac disease is all important. Again, the contact for the provider is important so that the interpreting provider can contact you if something of emergent is discovered during the scanning or even during the interpretation process. It is important that you include the indication for the study, because, for example, if you put an indication, say syncope, as a reason for doing your study, I'll be looking at the study from that perspective and to provide you with some answers to say whether there's a cardiac reason for the syncope. So, for example, I want to know where the coronaries are coming from. And so my technician or my sonographer needs to define the coronaries. I need to understand the geometry of the ventricular septum to make sure that there's no pulmonary hypertension, because it could be a cause of syncope. If there's a stroke, I want to look at the atrial septum. Is there a PFO? Did the patient embolize something through the patent foramen ovale, which can be seen in about 20 to 30% of all people walking around? Is there poor growth? What is accounting for the poor growth? So the indication for the study needs to be clear, because it helps the interpreting provider to provide you answers specific to the question that you want answered. Especially in children, it is important that the weight and height is also included, because we index a lot of our measurements to the body surface area. And so we will calculate the body surface area with the weight and height, and so it is important. The performing personnel, either the sonographer or the interpreting provider, should note the blood pressure of the patient, because that is how you will be able to define sometimes pulmonary hypertension, because you're going to compare the systemic blood pressure to the pressure that is being generated by the right ventricle to say that whether your right-sided pressure is 1/3 systemic or half systemic or above systemic. And so all this biodata is very, very important. It is important for the person that is interpreting to tell you about the segmental relationship of the heart. Our right-sided structures located on the right side and our left-sided structures located on the left side. And because if they are not, it gives you a different diagnosis. For example, transposition of the great arteries, the aorta will be coming from the right ventricle, while the pulmonary artery comes from the left ventricle. So we need to define the segmental relationship. We need to tell you something about the systemic and the pulmonary venous anatomy. And so that should be included. We need to tell you about chamber sizes. Is the atria dilated? Is the ventricles dilated? Those are all important things that we interpreting should convey to you. We need to tell you about the valve anatomy. Is the tricuspid valve okay? Is the mitral valve okay? What about the pulmonary valve? And what about the aortic valve? Is this a bicuspid aortic valve? Because if it is a bicuspid aortic valve, that patient needs follow-up. That patient needs a lifelong cardiology follow-up because there could be consequences with bicuspid aortic valve. And so we need to tell you whether it is a tri-leaflet valve or not. We need to tell you about the great arteries, the pulmonary arteries and their branches, and then the aorta and the aortic arch. In as much as we can, we need to tell you about the origins of the coronary arteries. Are they coming from where they are supposed to come from or not? Then we need to tell you a little bit about some extracardiac things, including pericardial effusions, which can also impact the heart function. So this is kind of one image here that we are looking, and this is a parasternal long axis view. So this is anterior structure. So our right ventricle is here. This is our left ventricle. This is our mitral valve, left atrium, and this is the aorta. But if you look here, we have our ventricular septum in this plane. What you realize is that the ventricular septum is sitting just about in the mid portion of our aortic valve. And so just from this plane, I could tell you that I'm looking at a ventricular septum override. And so I'm looking at something like tetralogy of Fallot type of picture because the aortic valve is overriding the ventricular septum. This is not a normal anatomy. And there's a hole here. And you see that there's a big VSD here. And this is for the interpreting doctor to be able to note, right? And to convey to you by piecing together from all the views that we looked at in generating the cardiac anatomy. Now, this is another view. This is an apical view of the heart. And right away, I'm looking at chamber sizes here. This is the left side of the heart, and this is the right side of the heart. Left ventricle, left atrium, right atrium, left atrium. Like I said, when I was showing you the still pictures, you don't define atrial septum from here because you can have dropout when you are looking at the atrial septum from this angle. And so you do see that there's some dropout here, there's a hole here. But the clue that I wanted to show you here is like, as we are looking at these chamber sizes, I realized that my right side structures is bigger than my left side structures. And that is abnormal. My right ventricle should be about half or 1/3 the size of my left ventricle. So if my right-sided structure or my right ventricle is bigger as my left ventricle or bigger than that, my right ventricle is dilated. And so I begin to think about what are the things that will give me dilation of my right side. And of course, ASD is one of them. This patient have a big ASD, but again, I won't diagnose the ASD from this view because I can naturally have some dropout and I may make some false conclusions. But by looking at the chamber sizes, I can have some sense as to what is going on. Again, this is a suprasternal notch view, looking from the top notch or just from the suprasternal notch. And we are looking at the aortic arch. We are looking at a portion of the pulmonary artery. And this is not to let you become cardiologists, but just show you some examples. And here we want to look at a PDA, right? A patient with PDA. So this kind of red color that you are seeing here is kind of the PDA that is coming from the aorta and going into the pulmonary artery. And we can look at it from various angles, but here we are able to look at it from the suprasternal notch angle. We look at the aortic arch that appears to be patent with blue color going away from us, and red color will be the moving towards our probe. And if you look at your marker of the probe, this is where your probe is sitting. And so anything that is moving away from your probe will be blue, and anything moving in the direction of the ultrasound beam or your probe will be red. This is another apical view. Now here we're looking at, you remember I talked about the offset between the tricuspid valve and the mitral valve. If you look at this and you say, well, they are all on the same plane. Sometimes when you see them all on the same plane, that is not normal. But what we do see is that there is a hole down here, and that is the primum defect, what we call a primum ASD, or what we call partial AVSD, right? So when we are looking at atrioventricular septal defect, sometimes you will see a hole down here, and then we will see a hole here. You can make a diagnosis of primum defect from this view, from apical view, because the primum septum kind of lines out a little bit better. But if you want to talk about your secundum septum, then you can sometimes make some mistakes if you are looking at it from this plane. Again, here our right side structures is a little bit dilated compared to the left side. There's another view here. Again, anterior structure, posterior structures, but here you see a big hole here. This is a perimembranous VSD that kind of extends a little bit into the muscular septum. So the septum, or the ventricular septum, have various components, right? It's a sigmoid shaped kind of three-dimensional structure that have a muscular component. It have a membranous or perimembranous component. It has an outlet component that kind of seals off our aorta and pulmonary arteries, and then also have an inlet component. And so when we are describing VSDs, we will tell you exactly what type of VSD that we are seeing, right? And so this one, me reporting will tell you I have a large perimembranous VSD with some muscular extension. Sometimes you could have only VSDs in the muscular septum, and we will tell you that it is a muscular VSD. And sometimes we should even be able to tell you whether it is anterior muscular VSD or mid-muscular or posterior muscular VSD. We need to tell you if it is on an apical VSD, because this structure here is called a moderator band in the right ventricle. And if my holes are below that, I should be able to describe to you that this VSD is an apical VSD. And they all have implications in terms of access to surgery and how easy we get to some of them, and whether some of them are going to stay open or whether they are going to get smaller with time. So this is a large perimembranous VSD. It's unlikely that it may get smaller, and this is the one that you may be repairing around 6 months of age. So quick one through, apart from looking at the anatomy and the gross anatomy, we need to be able to also tell you about the function of the heart, whether the squeeze is normal, whether it's depressed, and when it is depressed, the reporting provider should be able to tell you whether it is mildly depressed or moderate or severely depressed. And there are numbers in terms of ejection fractions that we can use to define that. We also need to look at the valves and make sure, is there the valves leaking, or is there stenosis, or is there narrowing of the valves? And we should be able to tell you that. Sorry about that. So this is kind of another view of the heart. Obviously, to tell you about the function of this heart, I'm sure you can guess right away that this heart is not just squeezing right? So this is a dilated left ventricle. The right ventricle is also dilated, but again, this ventricle is not squeezing. Look at your posterior wall and look at your septum. They are barely coming close together. So this is a severely depressed ventricular function. Now, we also need to be able to tell you about the valves. So look at, this is the aortic valve here, and this is the mitral valve. This is a patient with rheumatic heart disease. And our aortic valve is leaking like a pipe that has been opened. All this kind of color, yellow, red color, kind of going away from us is blood that was supposed to go up that is coming back. This is aortic regurgitation, and this is severe aortic regurgitation. You look here, this is the mitral valve. Again, the mitral valve is also leaking, but even if you look at it carefully, it's also not opening all the way. So there is a component or mixed disease of the mitral valve here with some mitral stenosis and mitral insufficiency. And we will be able to assess it better with some numbers in other views. But here you can just get a sense, and we can give you a sense of the function of the valves. So to summarize, the components of the things, the basics of cardiac imaging is to be able to convey important information about the anatomic and functional assessment of the heart. We should be able to answer answer the question about the indication for the study, we should be able to provide you, or the interpreting provider should provide you with important positives. We should also be able to provide you with some important negatives. And sometimes we should have recommendations. And sometimes I pick up the phone and call the ordering provider and say, hey, what I'm seeing is that you send this kid for a MEMA, and what I'm seeing is probably a small muscular VSD. I think this is not likely not to cause any symptoms. We can look again when this kid is about 3 months. And I'll choose 3 months because I know by that time the pulmonary vascular resistance might have fallen. Most small VSDs will close spontaneously. And so we'll look again and say 3 months, and then I'll be like, hey, it is still small. Why don't we look again and say a year? Or this is big, send this kid to come and see a cardiologist. And so we are able to provide some feedback for the ordering provider. And so that is what we should do as interpreting providers. We should be able to communicate with you as the ordering provider, and you also provide your contact, and you should be able to contact the person interpreting to help you with questions, especially in our setting in Ghana, where echocardiography is not so available and few people are doing it. They should be able to communicate their findings to us and to make sure that the report they are sending to us makes sense. A quick mention about cardiac CT scan. I'm not sure in Ghana we do cardiac CT scans. I know we do CT scans for a lot of other reasons, but the reasons why we would do cardiac CT scans is for coronary assessment, especially in adults, to look for coronary narrowings. But in children, for most complex congenital heart disease, for example, in my center, we do a lot of cardiac CT scans to help us define some complex venous, like pulmonary venous connections, or even some complex heart diseases. And then sometimes we will do it for functional assessment in patients with ICDs and pacemakers. Pregnant women, because of the radiation, sometimes we will not do it. People with abnormal kidney function, because of the contrast, is going to be filtered by the kidneys. Sometimes it can hurt us. Irregular heartbeats, especially if we are looking for coronaries, can hurt us. And people who are allergic to contrast, we try to avoid it. Same with cardiac MRI, is a non-radiation, so we can use this one in pregnant women, and it helps us a lot in defining cardiac muscle diseases like myocarditis, hypertrophic cardiomyopathy, or all the other forms of cardiomyopathies. We can assess that with cardiac MRI. Cardiac masses, we can tell you if there's a cardiac masses, we can tell you and give you defined properties of the mass to kind of narrow down whether we are looking at a mesoma or fibroma or rhabdos. We can use a cardiac MRI to define that. We can give you valve functions and especially calculate the amount of backward flow through valves. And this has been very important in defining when to operate on, say, aortic valves in terms of aortic regurgitation and the fraction of regurgitation. We can use cardiac MRI also for stress tests. We do that a lot, especially for patients who have had something done to their coronaries. We like people who have had repair of transposition of the great arteries with coronary movement and other procedures. We can use a cardiac MRI with some regadenoson, which is a type of adenosine medication to kind of stimulate vasodilation of the vascular coronaries and put the heart under stress to kind of get information about perfusion. Sometimes people are afraid of space, and so you know this wideboard magnet. Sometimes people who have severe claustrophobia, they will not do well with MRI. Sometimes with some sedation, we are able to get by. People with metallic implants, pacemakers, or defibrillators that are not MRI compatible, we cannot sometimes get good images. And so also with people with kidney functions, the contrast that is used in MRI, for the most part, very few people are allergic to the contrast that we use in MRI. So in conclusion, appropriate use of cardiac imaging is vital. We need to know exactly what we want. We should be specific and provide enough information for the sonographer and the interpreting provider. we should also try to provide you with answers in trying to interpreting the question that you seek to be answered. And there should be communication and professionalism, because bottom line of getting the test is to further patient care. And so if I see something that will impact the life of the patient, I should be picking the phone and I should be calling you to tell you what I'm seeing. And because I am a cardiologist, or I have enough information or understanding of what I'm looking at, should be able to provide you with some guidelines as to what do you do with the information that I'm providing for you. I hope I've been able to tackle the question a little bit, because as I said, it was kind of a way to say, what am I talking about here? Am I talking about the generation of images that is all about physics, or to kind of come up with something that can be beneficial to us as we request this test? So I'm happy to take questions if there's some time. Probably not, but also to note that the second annual, we have a whole cardiology conference for non-cardiologists from the University of Nebraska Medical Center. We did our maiden one last year across countries from Ecuador, Belize, Nigeria, Rwanda, Ghana, and it was a successful conference. We are trying to do again this year in conjunction with the Pediatric Society of Ghana. It's likely to be in February or April, so stay tuned if you're interested. Here you get a lot of bread and butter pediatric cardiology distilled in a form that you can use to enhance your practice and to provide good patient care. So thank you, and I'm happy to take questions if there's time.
I think we have time for maybe one question, if there's any from the group.
Well, if there are no questions, Dr.
I have a question for you, Ben.
Okay.
Hey,
Jim, how are
Jim
you,
Hami.
Jim?
Good to see you. That was wonderful. My main question for you is for the Ghanaian folks who might be wanting to utilize echocardiography to help diagnose their patients' lesions or lack thereof. What is your current assessment of the reliability of that? We here, I assume that when I order the test, that the results actually reflect the reality of the patient's anatomy, because there's so much experience and expertise. But that's echocardiography and ultrasonography is very, very user dependent. What's your current assessment of the reliability of the information that one can expect if they order that test in Ghana?
Yeah, I think it's a very, very good and very important question. And I have had calls that sometimes some reports are sent to me. And it was the reason why I incorporated a little bit into this talk about the reporting and what we need to answer, because sometimes some of the reports that I have seen sometimes doesn't meet kind of a standard kind of reporting standards, and even an attempt to answer the question for which the provider ordered the test for. And so that is a big question, I think, and I know there are moves with the upcoming cardiology group in Ghana to try and standardize some of these things, which is going to be very, very important to ensure that we provide the necessary standard patient care, because sometimes we can mislead. As I said, I've been to place in Ghana working, and I've seen some cases that have diagnosis of, say, ASD, and I have done the echo, and there's no ASD because probably they diagnose it from the apical four chamber where there's a dropout, and you don't, and this patient has walked around carrying the diagnosis of ASD or having a heart disease. And so I've seen some of those things, and I think it is incumbent on those of us doing those tests to appraise ourselves with the knowledge to be able to interpret well and do better. But I think it is a moving target. point of care ultrasound is creeping in, and that is providing some quick assessments in the emergency departments. And people are able to glean quick visual assessment of function, but that also comes with practice, right? To know that what I'm looking at is a normal function, and what is a mildly depressed function, and what is a moderately depressed function. And so I think there will be a learning and a moving target in terms of experience. But I encourage people who are doing those tests that it portends so much for people's life that we cannot take for granted to make sure that the reports that we generate for the doctors is reliable.
Thank you, Ben. That was great.
Yeah, again, thanks for presenting today and for offering up another educational opportunity for the group. If you want to send me information on that, I can help distribute that as well. That's
I will.
That's what Africa Partners is about, is partnerships and helping get good information to everyone for your own practices. We had intended to take a short break, but considering that we're running behind, I think we'll just press forward, and I'll just leave it up to each of you if you need to step away for a few minutes, either to use the restroom or eat something. But our next speaker, Dr. Sunil Mehta, will be speaking next, and we'll just go through his talk, and then shortly after that, we'll go into our breakout groups. So thank you.
Hello, I'm Sunil Mehta. I hope everyone can see and hear me okay. I'm about to share my screen. Okay, hopefully that shows up. So today I'm going to be talking about the assessment of autism spectrum disorders. This is a very broad topic, and I tried to condense about 4 to 6 hours of lectures that I give to residents and fellows into about 20 minutes. I am fortunate enough to be followed by a nurse and social worker from our team, Sarah Huskis and Jenny Chapesky, who will be doing a breakout session after my talk. And so I've left some time at the end for people to ask questions, and I would strongly encourage you to do so if you have some, but if you don't, I'll lurk around the breakout session as well, if you think of questions then. All right. So I have no financial conflicts of interest. And in terms of learning objectives for today, I'd like you to get 3 things out of this. 1 is to understand the diagnostic criteria for autism spectrum disorder. 2 is to identify screening and diagnostic tools that you might be able to use in your practice setting. And then the big takeaway that I want you to get from this talk is to recognize comorbidities that occur with autism spectrum disorder, and how really as medical professionals we can make the lives of patients and families better who have this condition. So first, what is autism spectrum disorder? The Diagnostic and Statistical Manual, DSM-5, defines it as someone who has persistent and functional difficulties in 2 domains. One is going to be in social communication, and the second is going to be in restricted and repetitive patterns of behavior or thought. So in order to make a clinical definition of autism spectrum disorder, someone has to have deficits in social communications that impair their functioning in day-to-day life in these 3 areas that I've listed below. 1 is deficits in social emotional reciprocity, and this could be incorporating things like eye contact, or how much someone is able to share interests with other people. It could be involving emotion regulation, and it could be how someone can respond or initiate to social interactions. In children, this is most commonly observed through play. And so one other thing before I go much further into the idea of autism spectrum disorder is it's important to recognize that autism spectrum disorder is a spectrum for a reason. And so in any of these domains, you can have symptoms ranging from very mild to very severe. And there is no one behavior or symptom that automatically means you have autism. Likewise, there is no one strength or skill that you can have and that automatically rules out that you have autism. So very commonly, we will hear from parents or other professionals, my child makes eye contact, so they cannot have autism, and that's not true. The second area in terms of social communication that can be impacted would be deficits in nonverbal communication. So again, this could be eye contact. In different cultures around the world, hand gestures are used more or less when people speak. And this also can include someone's ability to interpret nonverbal cues, such as facial expression in other people or body language. And again, depending on culture, sometimes this is used more or less than just verbal communication in terms of getting someone's point across. Finally, in terms of social communications, people with autism often have deficits in developing, maintaining, and understanding relationships. So this can include difficulty making friends or an absence of interest in playing with peers. You can also have a deficit in terms of understanding what someone else is thinking or feeling, or the nature of certain relationships, such as marriage or things like that. The second domain that someone with autism has to have deficits in, and here you don't have to have all of these, but you just need 2 of these. One could be stereotyped or repetitive motor movements. So motor stereotypies are generally repetitive, somewhat complex motor movements. The most common one that people will describe is hand flapping, but this can include behavior involving the eyes, the head, the neck. It can sometimes be a little bit difficult to distinguish between motor stereotypies and tics. Tics are, again, rapid involuntary movements that typically involve just one muscle group, whereas motor stereotypies can involve multiple muscle groups. In addition, motor stereotypies in autism are generally considered to be soothing or providing sensory input that the child would want, whereas tics, again, are are involuntary and the child generally has no control over them. Likewise, as far as repetitive or stereotypes movements, repetitive play, such as lining up toys or arranging things in a certain pattern every single time a child plays with them, is a sign of repetitive interests. This also extends to media use, which now is becoming more and more of an area that parents will bring up. So if a child wants to watch 5 minutes of a movie or a video again and again and again, that would qualify as being a repetitive interest or movement. The second domain, or the second area of this domain, is an insistence on sameness. So many children with autism will need to do things in the same order in a certain way. For example, they will only eat certain foods before they go to bed, or when they wake up, they may need to do things a certain way or arrange their room in a certain way. And here there can be some diagnostic overlap or some confusion about another condition called obsessive compulsive disorder. The difference between the two can be difficult to distinguish, but generally in obsessive compulsive disorder, people need to do things in a certain way in order to prevent some sort of disaster, like they or their family would get sick if they don't touch the doorknob in a certain way every day. Whereas a person with autism may do the exact same behavior, but it's not to prevent something bad from happening. It's because that's just the right way to do it. And it's important to distinguish between the motivation of why a person is rigid or inflexible, because that makes a difference in terms of what treatment would be helpful. People with autism can also have a highly restricted or fixated interests. And this is one area where sometimes people with autism can have talents that go above and beyond neurotypical peers. In the media, you may have seen portrayals of people who have amazing memories and can memorize thousands and thousands of facts. And those people end up being on the autism spectrum. It doesn't have to be to that extent, but if a child is very interested in a particular topic, and the main diagnostic sign that you want to look for is, are they able to talk about something else? So if you're talking with a child and they are very interested in animals or baseball, and then you change the topic, if they bring it back to whatever they were interested in and they will not change the topic of conversation, that's a sign that it's a highly restricted and fixated interest. And then the final area of restricted and repetitive behavior to keep in mind, and this often has a very significant impact on children's lives, is sensory sensitivities, either hyper or hyporeactivity to sensory input. Again, the most common manifestation of this we may see is auditory sensitivities, where in loud environments that other children might be a little uncomfortable with, a child with autism would cover their ears and try to escape because it significantly hurts them. Likewise, some children with autism can have a higher than normal pain tolerance, or stimuli that normally would hurt a child of the same age they don't seem to react to. Children with autism can also have unusual sensory interests, so excessive smelling or touching of objects. And one other sensory behavior that I wanted to highlight or point out to you was that children with autism often have is something called peering behavior, where they may be interested in a toy just like any other kid, but they would be interested in specific parts of the toy. So for example, a toy car, a child might bring very, very close to their face and look at because they're interested in the small details of the door or the wheels. In terms of diagnostic tools and used for the assessment of autism, the gold standard diagnostic tools that are used in the US and largely in Europe are the ADOS, which is the Autism Diagnostic Observation Schedule, and the ADIR, or Autism Diagnostic Interview Revised Form. These, the ADOS in particular is a very sensitive and specific tool, but it is not yet cross-culturally valid or valid in languages other than English. There are a lot of active research groups trying to adapt the ADOS to other cultures and other languages. But right now, in the US, when we get families who have immigrated or children who do not speak English, the ADOS is not going to give us a very informative answer as far as whether this child has autism or not. And so generally for folks in other countries, I would not recommend using this. The other challenge in terms of spreading the ADOS or the ADIR to places around the world is the cost and the time and the training necessary to administer these tests. So for example, the ADIR, in terms of administering it to parents and scoring it, can take up to 6 hours. The ADOS can generally be done in 2 hours, but it requires a 2-day in-person training course before you can be certified to use it. There are tools that are more widely accessible, and people are have made more progress in terms of translating these for a global audience. So one tool that is very commonly used in pediatric practices across the US and Europe is called the MCHAT, or Modified Assessment Tool for Toddlers. This has been translated into 50 languages and counting. There have been peer-reviewed studies looking at its efficacy, sensitivity, specificity in Spanish, Arabic, Chinese, and other languages. It's a free tool, so anyone can download and use it. And the website that I put up here has very clear scoring instructions. So it's The MChat, though, is a screening tool, and it's intended for use in children between 16 and 30 months. Children who score positive on the MChat have about a 50% chance of being on the autism spectrum when we do more in-depth diagnostic testing. But about 94% of children who score positive on the MChat have some sort of developmental delay. So in a primary pediatric practice, this is very useful in identifying those children who need to go on to further screening or further testing. I wanted to briefly talk about a tool called the Childhood Autism Rating Scale, or CARS-2. This is a tool that is administered by a clinician. It doesn't require as much in-depth training or specialized equipment as the ADOS does. It's not a free tool. It does have licensing requirements. And I put the website up where people can look up how to get it if they're interested. So far, it's translated into 8 different languages, but people have not done a lot of rigorous research in terms of how sensitive and specific it is in those other languages. So the numbers that I'm quoting you here are, again, for the CARS in English. It's a diagnostic tool that looks at 15 different domains that map on very strongly to the DSM-5 criteria for autism spectrum disorder. This tool is primarily based on clinician observation of the child. It involves a clinician, nurse, physician playing with the child, but there's not a specific set of toys or items you have to use. It also comes with a parent questionnaire that can be very helpful for supplementary information. But I would caution you against simply transcribing what parents say their children or their child is like and just scoring the form. You really have to incorporate both parent information as well as the clinical observation of the child for the tool to be accurate. The other limitation of this tool is that you have to have some measure of a child's intellectual functioning, because that's one of the domains that you're going to be scoring in order to use this tool accurately. And especially for younger children, that can be difficult to do because depending on where you are, you may not have access to IQ testing, either through the school system or through colleagues in psychology. Really quickly, just one thing I wanted to ask with the Zoom layout, I'm hoping that everyone can see all of my slides, but if something is cut off, let me know. Here at Mayo, for younger children, we will often use other developmental screeners, such as the Developmental Profile 3, to get a rough idea of a child's intellectual functioning. In other settings, you can get input from teachers or preschool providers. But if you have a child that you think is significantly a risk for intellectual disability, you may need to assess that first before using a tool like this to look for autism. So next, I wanted to talk about what causes autism spectrum disorder. And before we go into the causes of autism spectrum disorder, answering this question is a little like answering the question, what causes fever? So autism spectrum disorder, although we have a set of diagnostic criteria, it is not one illness. There are probably 1,000 different forms of autism. And there are many different etiological causes of autism. And the reason we call all of these things autism spectrum disorder is because they have certain features in common. But biologically, many different things can happen to cause autism spectrum disorder. So far, every known type of autism spectrum disorder is the result of abnormal or divergent neural development, likely starting in utero. There are no known causes of autism that occur after birth. You will sometimes run across patients or parents who say that my child was developing normally up until a certain point, and then suddenly they stopped talking, or they had a significant decline or decrease in function. With certain neurological infections or signs of neuroinflammation, we have seen that symptoms of autism spectrum disorder can get much more severe after those things. But when you go back and look carefully at this child prior to that insult or infection, the signs of autism spectrum were there before. And then one question in terms of causes of autism spectrum disorder that many people have is genes versus the environment. And we now know that it is likely an interplay of both, but we'll talk more about that in a second. One thing that I wanted to also highlight or raise was what does not cause autism spectrum disorder. So autism has behavioral manifestations for sure, but it is not a behavioral problem in and of itself. It is not caused by poor parenting, lack of discipline, lack of morals. And while parent training, parent intervention can be very helpful for children with autism, I feel that as medical providers, one of the most helpful things we can do for families with children with autism is to help them understand that it was no one's fault that this happened to their child. Again, as far as finding the cause of why this happened, there can be thousands of different causes. 99.9% of the time, identifying the cause does not make a difference for the child as far as treatment. And then the other points that I wanted to make as medical providers, it can be helpful to share with families that the question of autism and the link with vaccination has been studied incredibly intensively. Hundreds and hundreds of thousands of children across the world have been looked at, and in no study has there been a link between vaccination and autism. Well, I should say no credible study that hasn't been retracted. In terms of environmental risk factors for autism spectrum disorder, there are three main environmental risk factors that I feel you should be aware of, because again, from a public health standpoint, these are things that we may be able to do in terms of reducing the prevalence or incidence of autism spectrum disorder. So there are certain prenatal infections that when the mother gets this infection during pregnancy, we know this leads to a higher risk of autism spectrum disorder in the child later. These are primarily the torch infections, so toxoplasma, especially rubella, influenza during pregnancy also has a significantly higher risk of both autism and ADHD in the child later. And so vaccination against influenza in pregnant moms can be very helpful. One question that has come up very recently is, do prenatal infections with Zika virus or COVID cause autism spectrum disorder? COVID has not been around that long, but initial and preliminary data suggests no. Zika hasn't been around for a while, and while Zika has profound neurodevelopmental defects in children when the mother gets pregnant, when the mother has a Zika infection when pregnant, autism spectrum disorder is not one of those conditions that is caused by Zika. There are certain medications that when moms take, if they're pregnant, they can greatly increase the risk of the child having autism spectrum disorder. The best known of these is Depakote or valproic acid, which is an anti-seizure medicine. It is also sometimes used in bipolar disorder. So if there is a woman taking these medications and there's even a possibility of her getting pregnant, they should, or if they have a positive pregnancy test, they should find alternate medications to take. Recently in the US, there has been some interesting epidemiological studies involving geotagging, or seeing where on a map cases of autism spectrum disorder tend to cluster. And there has been some association with freeways. And so there is ongoing research into determining if ultrafine particles from cars or other industrial pollutants, if exposure to those during pregnancy has a link or to autism spectrum disorder later. There has also been a lot of research into whether heavy metal poisoning, mercury, lead, other industrial pollutants is linked to autism. Again, like Zika, being exposed to these substances during pregnancy is bad for a child's brain. There is definitely a higher incidence of intellectual disability and learning disorders when a developing fetus is exposed to mercury or lead, but so far we have not seen a link to autism specifically. Finally, prematurity by itself is a risk factor for autism spectrum disorder, as well as other neurodevelopmental disorders. A recent study showed that about 22.6% of children who were significantly premature, so born at 25 weeks, had autism spectrum disorder that was diagnosed by the time they were 3. There is an association with low birth weight as well. And the effect of prematurity and low birth weight is more pronounced in girls than boys with autism spectrum disorder. I also wanted to talk quickly about autism genetics. So far, over 700 genes have been implicated as risk factors for autism spectrum disorder. There are multiple biological pathways that we know are important in autism spectrum disorder, ranging from synaptic function to chromatin modification to genes involved in neuronal migration and wiring. Now, in the US and Europe, standard of care is to offer genetic testing to all children with autism, but it's important to counsel or to know that no answer on a genetic test is generally going to point to a specific treatment for a child with autism. The reasons to get genetic testing in a child with autism partly is family planning. Here in the US, if a child is positive for a mutation we know is linked to autism, then we offer to test the parents as well. And then parents can have a much clearer idea of what their risk of having another child with autism would be. The other reason to get genetic testing is there are really 2 kinds of autism spectrum disorder. There's what we call simple autism, where a child has all of the behavioral features or issues outlined in the DSM-5 criteria that I mentioned before, but that's it. They don't have other medical involvement. And then there's syndromic autism, where a child has all the behavioral features of autism, but it's part of a larger medical syndrome. And syndromic autism is much more likely to be associated with a genetic mutation that we can identify. Again, depending on where you are, the availability and cost of genetic testing may vary. But when we test children with autism, the first line genetic tests that we would generally do would be testing for Fragile X syndrome and to do a chromosomal microarray, which looks for small breaks or duplications in the chromosomes. When we do those 2 tests on, say, 100 children with autism, around 15 to 20 of them will end up being positive. So the majority of children that we do genetic testing on end up being negative or normal, but that rate is about 100 times higher than it was 10 years ago when we just did karyotypes. Again, in the US, the second line testing, genetic testing, if the chromosomal microarray and Fragile X testing are normal, would be whole exome sequencing. This gets significantly expensive, and even here, insurance does not always cover it. When we do that on 100 children with autism, somewhere between 35 and 40 of them will end up being positive and find a mutation in a gene that is linked to autism. So how can medical professionals help people with autism? Or what is your role as a medical provider? I show this picture because for many children and many adults with autism, every day, your normal daily activities, going to school, going to work, it's like running a marathon. So things that we all take for granted, situations that we all take for granted, are significantly harder for people with autism. So it's like running a marathon, except you have a backpack full of rocks. And as medical providers, some of the most helpful things we can do is to help take rocks out of this person's backpack. So they are running without carrying that extra burden. And one of the things that we can do to be most helpful for people with autism is to treat their comorbidities or other conditions that are associated with autism spectrum disorder. The most common medical comorbidities that occur in people with autism are issues with sleep and then GI issues. Between 20 and 50% of children with autism will have seizures. So if a child is having seizures, then putting them on an anti-epileptic, having them have a full neurological evaluation can be very helpful, because as long as a child is having seizures, it's going to be very hard for them to participate in therapy or learn. Between 10 and 40% of children with autism spectrum disorder will have intellectual disability, or what in the US used to be called mental retardation. Identifying those children can be very, very helpful for children and families, because as far as their progress or path in school, intellectual disability can make it much harder for children to absorb new information. So they may need to be taught differently or proceed at a different pace than other children in the same classroom. About 60% of children with autism spectrum disorder will also have ADHD, or attention deficit hyperactivity disorder. And while there is no medicine or no cure for autism, there are definitely medications or environmental modifications that can help with ADHD. And if we treat a child's attention or hyperactivity, then they will be able to take advantage of many of the other interventions that we would recommend for children with autism. And then finally, it's important to know that the rate of mental illness of other types is significantly higher in people with autism spectrum disorder. So the rates of depression and anxiety are about double that of the general population. Bipolar disorder in males is about double that of the general population. In females or women, it is about the same. As far as sleep and GI issues go, one thing that is likely to be widely available is a supplement called melatonin. Melatonin is a hormone that is involved in regulating our circadian rhythm. And there has been some research showing that children with autism or other neurodevelopmental disorders, they produce melatonin, but they don't produce it in the same pattern as neurotypical people. And so in most people, every night, there's a spike of melatonin produced by the brain that helps reset someone's circadian rhythm or internal clock, and helps their bodies tell the difference between daytime and nighttime. Taking supplemental melatonin every 24 hours can help regulate the sleep of children with autism spectrum disorder and keep them on a regular pattern. I would not recommend using melatonin as a sedative or a sleep aid. What it's really helpful for is sleep training. There are many other sedating medications that people use to try to help a child get to sleep. These can be helpful, but it's important to remember that all of these are temporary measures. So no matter what you use to help put a child to sleep, eventually the child will get used to it. So there is no medicine that long-term will solve a sleep problem. You can use the sedating medicine in the short term to help start a pattern of regular sleep, but yeah, you have to do other things in terms of behavioral strategies and management in order for that to be effective. As far as GI issues go, one GI issue that I want to highlight and make sure that everyone is aware of is that constipation is a fairly common problem in children with autism. Sometimes this is related to children having a very restricted diet and only eating 1 or 2 types of foods, but there are children who have a fairly varied diet who will also have constipation. This is thought to be another manifestation of a neurodevelopmental disorder. So you have an entirely separate nervous system that innervates your gut, but those cells start out from much of the same populations that will form a child's brain. Treating constipation, screening for constipation, can be enormously helpful for children with autism, because many times we find that treating constipation will lead to improved behavioral outcomes as well. When a child is very uncomfortable with constipation, again, their ability to respond or participate in therapy is very limited. And children with autism who have significant communication delays, they may not be able to tell you that they're in pain or that they feel abnormal, and they may not perceive this feeling as abnormal or pain the way other children might, because they've just lived with it their whole lives. Our nurses and social workers are going to talk more about the treatment of autism in the breakout session, but I did want to provide just a brief overview. So there's a type of therapy called applied behavioral analysis, or ABA therapy. And this type of therapy has the best evidence that we know of for improvement in children with autism. However, it is not widely available, and it is very expensive and time intensive. So in its most traditional form, applied behavioral analysis is about 40 hours a week of one-on-one therapy with a child. That is, even in the US, getting into ABA is a significant barrier. For children who are not able to get into applied behavioral analysis, often socialization or social skills training through a school-based setting or speech therapy can be very helpful for children with autism. The primary goal of any therapy for autism in young children should be improvement in communication. When we have followed children who were diagnosed with autism at age 2 and saw what kind of lives did they have when they were in their 20s, the two biggest factors that determine their quality of life was their IQ, or cognitive function, and that just is what it is. There's nothing anyone can do about that. The other factor that made a big difference in their lives was their ability to communicate. So the more a child with autism is able to allow other people, not their parents who become really good at reading their minds, but other people to know what they're thinking, feeling, what they want, and what they need, the better lives that they will have as adults, the more they will be able to participate in work settings and have relationships as well. So the main area that we want to focus on in children with autism, regardless of the modality of therapy or the type that's available, it should be aimed at improving communication. So thank you very much for your attention. And I just wanted to open it up for questions.
Thank you so much, Dr. Mehta. Any questions for Dr. Mehta before we head to our breakout sessions?
Hello.
Hi.
Hi, Dr. Mehta. Thanks for the presentation. Very good one. I was just curious, in your practice, have you seen any increase in the number of autistic patients with the pandemic, with COVID? I was just curious.
So I am probably the wrong person to answer that question, because even prior to the pandemic, our practice was incredibly busy. We have somewhere between a 3 to year-long waiting list, depending on the age of the child, to get in. So we were already very, very busy. I can tell you that with the pandemic, the acuity of the children that we are taking care of on an ongoing basis, as well as the new ones we see, they are struggling. So the changes caused by the pandemic have been very hard on children with special needs in general, but especially for children with autism. Some of the sensory issues make masking challenging for them. The children who did have significant supports with therapists, once that became virtual, it just didn't work for them. And so in that sense, I do think that from a population standpoint, I don't think the prevalence or rate of autism itself has gone up, but the children's needs have certainly gone up.
Okay, thank you very much.
Mm-hmm.
Any other questions for Dr. Mehta? All right. Well, if there are any, I imagine that Dr. Mehta wouldn't mind being contacted directly. I'm offering that up without asking in advance, but I think I'll head
please do
on the spot there. And then I will, if you can send me your slides, I'll distribute them to the groups as well. What we're going to do now is separate into a breakout session. I'm going to open a breakout room that's entitled Nurses Breakout Session. This isn't necessarily exclusive for nurses, but if you want to participate and hear more about supporting children and families with autism diagnoses, and then subsequent to that, some information on patient-centered care and compassionate care, you can join that breakout area. Otherwise, you can remain in this room, and we'll have some interactive sessions on common neonatal anomalies. Because of the timing, we're going to adjust the end of today's session a little bit. We had a half an hour scheduled to return for wrap up, but I think we're going to cut that down to just 15 minutes so we can remain in the breakout sessions until 1:45 Central Standard Time, which would be 6:45 Ghana time. And if you have questions, you can message me directly through the chat. So I'm going to open up the breakout room and you can self-assign. All right, we've had several join the breakout session, so I'm going to presume that those that wanted to have been able to do so. If you still aren't quite sure how to do that and you want to join the other one, just send me a message in the chat and I can assign you directly. Otherwise, we're going to turn it over to Dr. Forson. Thanks for leading us in the next portion of our time together.
Oh, hello, everyone. I'm just going to try and share this screen. Here we go. Just let me know if you can. Okay. Can everybody see my screen all right?
Looks good, thanks.
Perfect. Okay, so I'm Dr. Forsendare Zanetta. I'm one of the, I'm a neonatal perinatal medicine fellow currently. And today in this session, we're hoping to go over some common congenital anomalies, go over sort of the definition, we'll go over diagnosis and immediate management, then long-term management. So this is supposed to be an interactive session. If you have any questions, please feel free to stop me at any point and I will kind of, hopefully this works best if we can all interact with each other. Okay, so the WHO, just to start off, defines, a congenital anomaly or birth defect as either a structural or functional anomaly. That's so that it can include metabolic disorders that occur during intrauterine life, and either we can identify this prenatally or at birth, or sometimes it can't be detected until much later on in infancy, some things like hearing defects, because that's much more dependent on being diagnosed, like based on an interaction with the infant. Why are they important? So I think it's very important for us to be able to identify and manage them because they're a major contributor to neonatal mortality. You know, almost 300,000 newborns a year die within that first month of life due to one type of congenital anomaly or another. There's a lot of short-term morbidity, mortality, and then long-term disability that's going to affect not only the patient, but also the family and the society. It's difficult sometimes to identify exactly why these things happen. There are lots of contributors. Some things are genetic, some things are caused by infections that the mother may have that then cause congenital anomalies in the baby. Some are nutritionally dependent on the nutritional status of the mother, and then others based on environmental factors and toxins that the mother may also be exposed to. And some of them can be prevented. So it's important for us to know which ones those are and how to do that. This is just kind of reflecting that their importance, that the orange segment here represent the congenital anomalies. They do represent a significant cause of neonatal death. This is from the WHO report in 2016. Things that were more significant, obviously preterm delivery and then also birth asphyxia, and babies who are born with congenital anomalies are also more likely to be born preterm. So there's like some compounding morbidity there as well. And so part of our session today is to contribute to this sort of WHO resolution on birth defects to try and develop all of our ability, our expertise to kind of diagnose these illnesses. And then in order to be able to diagnose them, to be able to prevent them. So to prevent them and then enable better management of them in the neonatal period. Okay, so I thought we could start off with you guys telling me some of the common things that you have seen or that you have learned about in terms of congenital anomalies. Just feel to either you can put stuff in the chat or you can just shout them out, anything really.
I remember the first time I visited the mother-baby unit at Confanote Teaching Hospital and seeing a baby with gastroschisis there.
Yeah, that is definitely one that we see on a more common side. Has anyone else seen anything or learned about anything that they feel comes up pretty frequently? So you can just go through some of the ones that we tend to see here, and often they will not have. Some congenital anomalies will have differences in presentation between countries and between races, but a lot of them do present with pretty similar levels of prevalence. So things that we see very frequently, so cleft lip, palate, congenital heart disease, spina bifida, gastroschisis, that Dr. Homey just said. Oops, I'm putting in the chat. Yep, cardiac is very, very common, VSDs and ASDs. Do extra digits count? Yes, so that is a congenital anomaly. That is something, polydactyly, something we do see frequently. I haven't got it here, but that's a very good point. Other gastrointestinal issues such as tracheoesophageal fistulas, esophageal atresias, and then syndromes. So trisomy 21 is definitely one of the most, or the most common trisomy that you see in the general population, and that does not differ across the world, and then kidney renal issues as well. So we'll start with a case. So this, from the next part of the session is really going to we're going to go through 4 cases just to try and highlight some of the more common things and for us to come up with management plans of what we would do, in the immediate period. So I'll start by reading out this case, but and then we can go on after that. So you're in the pediatric clinic, you have a 4-week-old baby who's been brought in by his parents. they report that he's not really been gaining weight. He had that, he hasn't switched from, that first 2 weeks of weight loss to increase. That hasn't happened, and often seems quite tired and a bit sweaty when he's trying to breastfeed, and has to stop pretty often when breastfeeding. The mom feels like he breathes very fast, and when she holds him against her chest, she feels like his heart rate is also very fast as well. So you guys tell me what other things you might want to know from this family. And again, in the chat, it's fine if you don't want to say it, but also feel free to just unmute and let me know. This can be just, we go through everything as we would for every child who comes in, or adult who comes in trying to figure out what's going on. We always start with the history and then the physical. So what are the things in the history that either concern you or things that you would want to ask? Let's see. Oh, yep. Any blue spells. So, yep, that's a great point. Any signs of cyanosis or and is there some kind of pattern to it? Anything else? So you want to characterize everything, right? So they say this has been going on for 4 weeks. Has it been slowly getting worse, or has the baby been the same since they were born? Is there anything that's been a sudden deterioration in the last couple of days? Anything you're trying to think of your differential diagnosis of a baby, essentially a 4-week-old who's not growing, who's having tachypnea, and who also appears to be slightly decompensated, like slightly sweaty and tired. And so you want to ask about any other sick members, of the family. Has the baby had any fevers? Has the baby, as yet, had any blue spells? Any other respiratory symptoms? You want to ask what other cardiac symptoms? Has the baby been completely alert and awake? Is there something that is coming and going? And what has the baby been receiving? So is it just breast milk? Is the baby receiving any other types of foods or any type of medication? So you never assume, that you know what is going on. So you just take your full history. And then when we look at this history, so this was any maternal illness is perfect. Okay, so starting with the prenatal history, there you go. Okay. And any family history of cardiac disease. Did the baby have the CCHD screen and results of the newborn screening? So thanks, Dr. Hobby. That's really essential stuff that we want to find out. So looking at the birth history, so this was a full-term baby, it was vaginal delivery, there were no issues there. And no issues, I also mean they didn't pick up anything on the prenatal screen. The mom did have an ultrasound, but they didn't have, there was nothing abnormal there. The baby itself, it really has looked pretty much the same. So there's no past medical history. That's one of the great things about pediatrics. 1-month-old often doesn't have any other history. There's no recent fevers, no sick contacts, and no previous surgical history either. The parents are not giving any other medications, no other allergies. In terms of the social history and family history, they feel like there may be a cousin who may have had a heart problem, but they're not very sure. But all the current siblings of this child are all well with no further issues. Before we discharge any babies from the hospital, they have something called the CCHD screening, which we all know about. So that is where we check the oxygen levels on the right hand and any other extremity to kind of represent pre and post ductal saturations. And that would determine whether or not that's one of the ways to screen for cyanotic heart disease. So On the physical exam, this child appears quite tired, definitely tachypnic, everything else feels kind of clear. You can hear this holosystolic murmur, which is loudest on the left sternal border. The capillary refill looks okay, the pulses are okay. There's a little bit of mild hepatomegaly, and otherwise the abdominal exam is fine. And the baby is alert, has a normal tone. So what do we think, based on the things we've figured out so far, what else might we want to do for this child in the immediate period? What investigations would help us at this point? Great. Chest X-ray. So we do have the chest X-ray. Fantastic. Does anyone want to kind of just go over this X-ray? You can put into the chat any major things that you can see. Yeah. So the heart does look big on this view. Yeah, prominent pulmonary markings. So those are the two sort of, biggest things that we see that we're going to get from this chest film. Just always as a point for chest films, obviously this NG tube is not necessarily useful for our case. It just happened to be on this film, but always pointing out the lines and any extra things that the baby might have, like medical equipment wise. So we have a 4-week-old who has kind of not even failing to thrive, has a murmur, and may have some family history of congenital heart disease, and on our chest X-ray has an enlarged heart. I will say that a lot of radiologists will tell you that on the AP film, which is what all neonates are going to have in terms of a chest film, because of the way because they have to lie supine for their chest films, that they can't confirm cardiomegaly because you need a PA film to be able to do that, but that this obviously does clear the heart side is very generous. And then we have the increased pulmonary marking suggestive of some fluid overload and increased prominence of the pulmonary vasculature. Okay, so we have essentially an infant who's presenting with some kind of, to us, congenital heart disease. Okay, so congenital heart defects are very, very common. Actually, one of the top 3 most common types of congenital anomalies. And we can go through. So this is just a quick reminder for all of us. We can always split them into acyanotic and cyanotic. So when we're thinking about the blue spells, babies who are persistently hypoxic after delivery and with murmurs, sometimes without murmurs, and no real evidence of lung disease, you're thinking down, these lines like the tetralogy of below, transposition of the great arteries. Transposition is the one time that you'll have that reverse split where your preductal SAT will be lower than the postductal SAT. That's the only, any other type of abnormal reverse split of your pre and postductal SAT is usually equipment related. Truncus arteriosus, and then total anomalous pulmonary venous return. And these babies often with TAPVR will present with severe respiratory disease, total whiteout of the lungs, and just nothing is improving it. There's no amount of oxygen that you can give that is improving it, and that's often that's one of the diagnoses to think about when you're in that situation on hypoplastic left heart. On the other side, we have our acyanotic defects. So these are pink babies. And of them, the most common is the ventricular septal defect, and that's the most prevalent in all countries. And then we have ASD, a PDA, which we know that 100% of babies are born with a PDA. We expect in full-term infants for this to close over the first 2 to 7 days of life. In preterms, the more premature you are, the longer it will take to close, and the less likely that it is to close by itself without requiring some kind of intervention, and the more likely it is to cause symptomatic issues for you. And then a coarctation of the aorta, where you're going to get differentials of the blood pressure and sometimes the saturation in the upper and lower limbs. You can also have that effect of reduced blood flow to the kidneys, may see decreased urine output and things like that, and can also cause decreased perfusion to the gut as well. So that's just a quick overview of the two sides. Thinking a little bit more about our baby. So with that holosystolic murmur at the left sternal border, in a baby who's, was fine at birth, went home, and now has, over the course of time, developed more and more symptoms, I always sort of think of a ventricular septal defect in those situations. So VSDs obviously are just a connection between the right ventricle and the left ventricle. Their presentation is so dependent on where the defect is, how big the defect is, and then any other associated cardiac anomalies. So they represent almost 40% of all congenital heart disease in children. And then an isolated VSD is in about 0.3% of all newborns. Most of them should close spontaneously. And so therefore the prevalence in adults is much, much lower, because they're not, they're improving, they're resolving. They affect baby boys and girls just about equally. And the definitive diagnosis is obviously going to be on an echocardiogram. That's not something that you may always have available in the immediate period when a baby comes into your clinic or when a baby comes into the emergency department. So we have to use the rest of our clinical exam and our history sometimes to narrow down what it could be, and then the echocardiogram to finalize that diagnosis. We heard a little bit earlier from Dr. Champong about sort of the usefulness of echoes and how to diagnose like the septal defects. So we don't need to go over that, but I hope this would work. Just in terms of our clinical exam, it was a really quick and cool YouTube video that just kind of goes over what you're expecting to hear, and that real location of the holosystolic murmur and how it sounds quite different to some of the flow murmurs that all babies can be born with. And it's just about, with auscultation, it's about listening every day. So you listen over the period of time, but also listening to the characteristic of the murmur. So we can listen to that very quickly if it will play. So you can see that we can hear the murmur kind of throughout the chest, but it is very loud in that left lower sternal border. So does anyone have any experience or has diagnosed these in the, any experience like diagnosing these in the postpartum unit, or kids that have come into the clinic? Any questions at this point just about that? Otherwise, we'll do just a quick overview of what we've talked about so far. You can put it in the chat too for me for later. So Think about VSDs, it certainly can be diagnosed on a prenatal ultrasound. That's usually done between sort of 18 and 22 weeks, but they're not always picked up. I mean, we have gotten very, very good at picking up congenital heart disease, and they're not always able to be detected. So often they do present in that postnatal period. And this is because the variation in clinical presentation is very much dependent on how big, the defect is. So the very small and restrictive VSDs will present with that an asymptomatic baby with a cardiac murmur. Often they'll, on day of life 1 or 2, be okay. And as the pulmonary vascular resistance starts to drop on day of life 2, and 3, then you start to hear this murmur, and it doesn't go away. It sounds very harsh. It has all of the clear characteristics. We would then get the echo, and that baby would be diagnosed with the VSD. And the reason why the pulmonary vascular resistance has to drop in order to facilitate that shunting from the left side of the heart to the right. And that's exactly what's going to allow blood to shoot across, and that's what's going to create your murmur. The moderate to large VSD, which is more what we were describing in this case, these are the babies that present essentially with progressive sort of congestive heart failure, because you are getting such, you don't necessarily hear as loud of a murmur, because if you think about it, the murmur is caused by the turbulence of a large amount of blood going through a small space. So if you have a larger amount of space, you won't get that turbulence as much, and the murmur won't be as loud. So you may not be detected in the well baby unit. And then if later on, they will get more symptoms of the tachypnea and the poor feeding, hepatomegaly. You do start to get obviously the crackles and the rails in the lungs. And the babies can appear very pale because they're vasoconstricted. So you can start with sort of a picture of like right heart failure, and then over a period of time that can also extend to left heart failure, so that you can get like edema and backing up into the further sort of hepatomegaly. The small VSDs will have a harsh blowing, like 2 out of 6 to 3 out of 6 murmur, and then the large, very, very large ones often may not have any murmur at all. On the EKG, which is another thing that you definitely should get in any child who has a murmur, you may see a variation of things, some right ventricular hypertrophy, left ventricular hypertrophy, and then again, the chest X-ray, as we showed, can show that evidence of left to right shunting, because if you think about it, the left side of the heart has a thicker wall, it's a higher pressure chamber, and so that's naturally that's where the blood should flow, the path of least resistance. If a child comes in acute shock, one of the things, and with a murmur, one of the things to consider is this cardiogenic shock as opposed to septic shock. And so it's the same initial management, right? So you're going to do ABC, so the airway, breathing, cardiovascular management, and then everything else. So we would start with getting oxygen, IV access. You want to make sure you have a blood glucose. And then where people often are worried is, so we have a child with a capillary refill that is prolonged, the child is clearly in shock, but they have a murmur. I'm not sure about how much fluid to give, or if I should be giving any fluid at all when I don't have a diagnosis. And I would say that most people would probably be okay if there was a small fluid bolus given, 5 to 10 mLs per kilo, until you, over a longer period of time, until you're more sure of what type of shock this might be. And then there's always the management of chronic heart failure, which we don't necessarily need to go into in this period, but that's just a general overview. And I think for us as physicians who may not be specialized in cardiology, one of the major things you're going to be contributing is facilitating growth of the baby, especially if this is a baby that needs surgical closure. Often babies with cardiac lesions need more calories in order to be able to grow, because they're using up a lot of energy, a lot more energy in the baby without congenital heart disease. So that's one of the things I just wanted to highlight, that this baby might need more calories, and that's either, it's usually going to be in fortifying the feeds. So breast milk and regular formula are about 20 calories per ounce, and often these babies need more, like 24 calories per ounce, which is measured out by increasing the amount of formula that you put into each ounce. All right, so that was our first case. The second case, so you're working in labor and delivery this time. You get called to review a full-term newborn who's just been delivered. The family reports that they've been told there was a problem with the baby's spinal cord that was seen on the prenatal ultrasound. And when you examine, there's a skin-covered lump it's partially covered with the skin, sorry, at the base of, at what age postpartum should be worried? So I would say, so I'm just going to answer this question quickly. I would say that if there are smaller VSDs that may still be present at a month or two of life, I often think the cardiologist will follow up more at like 6 months. I mean, they follow up frequently every 2 months of VSDs, 6 months for ASDs, but it's how symptomatic, if the baby is becoming symptomatic or unable to grow, or, you know, the VSD sort of getting in the way of any other normal baby thing, that's when I would still refer irrespective of the age. So if you have a small restrictive VSD that does not affect the baby in any way, and it is still there at 6 months, it definitely warrants a conversation with the cardiologist. They still may not do anything about it, but they would want to follow that baby chronically, just to ensure that some of the more long-term complications of having that shunting across the heart don't develop. I would just bear in mind some VSDs are actually diagnosed much later on in childhood, very rarely now because, you know, children are seen so frequently, but much later on in childhood. So my main thinking would be more in, is this VSD symptomatic, and is the baby affected anyway? And if you're really not sure either way, I think a discussion with the cardiologist is warranted. Okay, sorry. So just to go back to this, when you examine this, there is a skin-covered lump at the base of the spine, and the baby's not really moving the lower extremities as much as the upper. And I'll just take a picture just to show you. All these pictures are just on Google, so this one has the diagnosis in there. But has anybody seen anything similar to this, or has seen a myelomeningocele or a meningocele, which essentially is spina bifida? Have you had any experience with this? And then we can kind of go through what we're going to talk to the family about. Okay. So, great. Yeah, so these are also very, very common actually. And there's so many different different types. The one in this picture is a myelomeningocele. Let me just go through. All right, and they all come under the title of neural tube defects. And just to back up a little bit, so we have our case, you know, we think this baby has some kind of neural tube defect just based on the exam and the history, and just to understand where they come from. So this brief embryology. So, you know, the CNS starts as this, a plate of this thickened, so ectoderm is called the neural plate at the beginning of the 3rd week of life, so that's 21 days. And then we know that the lateral edges of that plate become elevated, and they're supposed to fold over and fuse to eventually form the spinal cord. The fusion starts up at the cervical region and then continues in both directions. And neural tube defects are essentially just a failure of that fusion. So depending on when it occurs and where it occurs, kind of explains why the different defects happen. So they're all due to failure of fusion between day 25 and day 27 after conception. So this is something that happens very, very early on in the development of the baby. These are just as a brief overview. The three ones that we see sort of the most, or talked about the most, are anencephaly, which is the open brain and lack of skull vault. That is caused by failure of the anterior neural tube to close. So all of the developing forebrain and the brain stem, they're all exposed in utero, and the amniotic fluid is very damaging to that exposed brain tissue, causing it essentially to not really form. This condition, unfortunately, is not compatible with survival, and babies often pass in utero or within a few hours after delivery. More girls than boys are affected, and there are some increased, some risk factors such as maternal hypothermia early in the pregnancy, secondary to any other sort of infection, and then folate and copper deficiencies. With this type of neural tube defect, 1/3 of these babies will have some other congenital defect as well. And then in the encephalocele is herniation of the meninges and the brain at the base of the occiput. And that's failure of the rostral part of the neural tube to develop. And then the thing that we see more frequently are sort of the myelomeningocele or the meningocele, which is what we'll go over more today. Any questions about that? Just wanted to show the variations of these. Okay, so as we can see, it presents with a lump at the base of the baby's spine. There's three sort of, we go along, like from the most mild to the most extreme. Spina bifida occulta is the most mild. This is where there is some abnormal formation of the vertebrae at that level. You don't have any herniation of the meninges or the spinal cord, but you may have some evidence that there is an abnormality there. It may be a sort of a tuft of hair or a sacral dimple, and that's one of our major, things we're looking out for in the well baby unit before babies go home. If you do have anything at the base of the spine, like an abnormal patch of skin, a patch of hair, a deep dimple, that where people will want to get a spinal ultrasound to ensure that there are no underlying abnormalities associated with the spine and the meninges. And then the meningocele is where you have herniation of the meninges, but the spinal cord is intact. And the most damaging, obviously, is the myelomeningocele, where the spinal cord is at really high risk for damage. So this occurs in sort of 0.1 out of 1,000 live births, so pretty, that's the encephalosphere. So just thinking about this meningocele versus a myelomeningocele is kind of what I already went over. That the meningocele is a spinal canal with the herniation of meninges, and then a myelomeningocele is a spinal canal with a herniation of meninges and the spinal cord as well. So this is something that you definitely will see. In some studies across the whole of sub-Saharan African continent, they found that the prevalence was around like 11 to 12 per 10,000 live births. And the main reason why this is one of the things for us to be really aware of is that it's a very preventable, well, at least we can reduce it significantly by ensuring all, I would say, childbearing age or people who are thinking about having children are taking folate supplementation. So it's not just at the time of pregnancy, but even 3 months before wanting to get pregnant, we should be encouraging all women to have folate supplementation. And that reduces the risk of neonatal defects by up to 70%. It can be detected prenatally with ultrasound, and any open defect where there is no skin covering has an increased risk of, will have increased alpha fetoprotein for the mother in the maternal blood. So that's another way that we can check it. And then the big thing is about the delivery center. So you may, the child may not be born obviously somewhere where there is a neurosurgeon. So many things are regionalized these days that we keep, like pediatric neurosurgeons would be usually in a big children's hospital. But to think about that in terms of, as you're initially planning what to do, where does this child need to go? So just think about the management. So the initial management, when you go to see this family, I didn't put it on here, but the major thing really with a lot of these congenital anomalies is going to be communication. So explaining to the family, they knew a little bit about what was happening, explaining to them exactly what it is, what it means, the next steps for them. The initial management, it's going to involve proning the baby to kind of protect that lesion, especially if it's open. Some centers, they cover the lesion with normal saline or cover the sac with sort of a sterile dressing and saran wrap. That's because it may be a direct, especially if there's a direct communication into the spinal cord. There is, you have to look for any other anomalies because there is a high risk that a child who has a spinal anomaly in this way may have some other anomalies. We want to determine the level of neurological function, which we'll talk about more later. And then the baby will definitely need an MRI or CT scan in order to really characterize the defect. And most of these will need surgical repair to improve optimize the baby's prognosis. Just a quick point about surgical repair. In a lot of, they're developing or have developed these really cool intrauterine surgeries to correct myelomeningocele. And that has been shown to increase the prognosis significantly, but a lot of babies are still corrected after delivery. So you go to, when you're speaking to this family, they ask you, what is my child's prognosis and what follow-up will they need? Does anyone want to take a chance based on what we've talked about, things that they might like to think about, tell the family, or even, contact a specialist to be able to answer some of these questions? You can put it in the chat too if there's anything that you think would be important for them to know.
Well, the level of the lesion makes a big difference on outcomes and function, the ability to ambulate or not. Most of these children with a lumbar sacral are going to have some degree of bowel and bladder dysfunction, if not profound, and that can have a big impact on quality of life and some, associated morbidity as well.
Yeah, absolutely.
Many have normal, like the lower lesions have normal cognitive function, quite often.
Yeah, absolutely. So, yeah, and this is kind of what we're alluding to. So, the level of the lesion is going to be really important in explaining to families exactly what the child's future may or may not look like. So, and the one thing that families often want to know when they hear about spinal lesions is really about, as Dr. Homi was saying, intellectual capabilities and also their ability to walk. And, because that comes along with their ability to do a lot of neurotypical childhood activities. Cervical and thoracic lesions, as you can imagine, the potential to walk is very, very poor. Even thoracolumbar lesions, it's still very unlikely. As you move into lumbar to sacral, they may be able to walk with braces on the sort of L3 to L4. And then by the time you get to S2 to S4, where those nerves to the lower limb have come off, they're usually able to ambulate without braces. But one of the major comorbidities has to do definitely with the GU system and their ability to pass urine without intermittent catheterization, and also with incontinence too, because that's one of the major complications that we see. And that can have a big impact on a family and a child socially and medically. Okay, so I think we still have a bit of time, sure. We can do the third case. So you're in the postpartum unit. Again, a 30-year-old G2P1 has come in labor. There's a prenatal diagnosis or highly suspected diagnosis of Down syndrome or trisomy 21. The parents would like to speak to you about what to expect after the delivery. So what are you going to tell them? And again, we can just put things into the chat. They want to know things like, oh, someone's in the chat. Great, yeah, so they're going to need screening for certain illnesses. They often have low tone and poor feeding in the chat, and then the child may have some developmental delay. It's always important for families to be aware of those prognostic issues. You have to expect some cognitive impairment. Great. All right, so yeah, I think that's important to explain to them what their child's life might look like, being very aware that there is a huge spectrum, and a lot of, though previously people seem to, always very sure that there's always going to be, severe cognitive impairment. That's actually not true. That there is a wide spectrum. I think one point that Dr. Tommy put in the chat that's really important is to also focus that there are lots of positives, and the child still does have great potential to experience a lot of very typical childhood and adult life, to go on to hold a job, to go on to sort of experience schooling, and sometimes even higher learning as well. I think that what I like to split it into is the medical things that they need to expect that we're going to screen for, and then explain there's going to be a wide variation of expectation for cognitive abilities, but that there is still great potential there too. Just going over trisomy 21, it's obviously the most common, affects 1 in 800 live births. This is just the karyotype. We can see there's one extra chromosome on the 21st chromosome. It's usually, the extra chromosome usually comes from the mother. And so 94% of the children you see with trisomy 21 have complete trisomy. 3 to 5% will have translocation, part translocation from another chromosome, usually 13, 14, or 15. And then 2% will have this mosaic type genetic picture where they are, it's not complete, the genotype is not completely penetrated, so the phenotype is slightly different. The mom also asks you, did this happen because I am, older? That's something that people think about too. And you can see that, yeah, there is like a change in the incidence and the risk, but as maternal age increases. However, what we do know is that most babies with trisomy 21 are still going to, on average, be born to younger women, just because most babies are born to younger women. So this is definitely an increase in risk as the maternal age increases. How do we diagnose it? If you guys tell me, what's your experience of the way it's been diagnosed in Ghana? Is it prenatally, postnatally? Like, what's been your experience so far? Postnatally, okay. And how is it diagnosed postnatally? What's the because we have the genetic testing that we can send, but I wanted to kind of find out from you guys what the availability of that is, the turnaround, and physical exam features. Okay. Yeah. So here, like, there are different ways that we can diagnose it. You guys have let me know that there is mostly postnatal diagnosis based on clinical features, which, because it has very characteristic clinical features. There's also prenatal diagnosis, from the fetal ultrasounds with the increased neural cord thickness, which is that the space at the back of the neck of the occiput is often thickened. There are also variations of blood tests that are done in pregnancies, and then postnatal would see that karyotype, and sometimes they also do a FISH, which is a very targeted genetic test to diagnose trisomy 21. But as you said, this is just a cartoon representation of some of the very typical facial features, and also includes some of the other complications that babies who have trisomy 21 can also have. So it's usually, the slanting palpable fissures, slightly flattened face, maybe low set ears. We have the single palmar crease, the sandal gap in the toes. And yes, some babies do appear very typically to have the typical features of trisomy 21, but it can be very hard to tell, especially sometimes in babies who are premature and also in the first few days after life. So it is fantastic if you can obviously diagnose with a genetic test, but if that capability isn't there, I would say even in a child who is suspected to have trisomy 21, the important thing is to address some of the complications before that child leaves and goes home. So let's say you've made the diagnosis. The biggest things on our that we want to ensure is a good cardiovascular exam. These babies are at very high risk for cardiac issues. We also want to ensure that we're getting a red reflex from the pupils and that we have assessed the respiratory status. We already talked a little bit about how they can be quite low tone and at increased risk for laryngomalacia and tracheomalacia, which will have respiratory decompensations. All children with suspected trisomy 21 or confirmed should have a hearing test. You definitely need a feeding assessment. A lot of babies with trisomy 21 will be able to feed just fine, but the combination of sort of low tone can make this very difficult. And they definitely may need some help with either NG feeding, or I've seen at times this has progressed even requiring a G-tube or a PEG. And then the screening blood tests that I think are essential before these babies go home. You want a CBC and a peripheral smear. This is to pick up any transient myeloproliferative disorders that they're very high risk for, and then also a thyroid function test, but you want to do this after they're a day old, because again, they're very high risk for hypothyroidism. So can anyone just think of any of the other complications? We already talked about the cardiac and endocrine, the extremities, we talked about some of the sandal gap, but anything else from these other systems that you know are possible complications of trisomy 21? Hirschsprung's disease, yeah. Learning disabilities. Great, yeah. So we have in cardiac, I would say it's 50% of cardiac lesions in babies with endoadrenal atresia, fantastic, yeah, have VSDs. They're also at risk for sort of PDAs, aortic regurgitation. The gastrointestinal things are duodenal atresia and Hirschsprung's. Those are the major things. Genitourinary, they are at risk for hypogonadism. Lots of infertility issues. Most female babies with trisomy 21 will have issues with fertile, have infertility issues. Then neurologically, we talked about the hypotonia. They can often have microcephaly and moderate to severe intellectual disabilities. They are for the other things. So we have major issues with sort of obstructive sleep apnea, which comes along with the low tone, as you can imagine. And then hematological issues with increased risk of leukemia, certain leukemias, the transient myeloproliferative disorders, which is why that CBC is important. And then also an increased risk of Alzheimer's disease, obviously a much younger age. Okay, this is the last thing. It should be pretty quick, but we can just stop me at any point if we're going over time. So listen, you're working in the NICU, a 36-week baby is about to be born with a known diagnosis of gastroschisis, and you are called to the delivery. What do you need to do or prepare to have in the delivery room? Has anyone had any experience of this? Or in the interest of time, I might just ability to cover the lesion. Perfect. Okay, so that's the most important thing, is to cover the lesion. You just need to protect it. And just watch it closely for any signs of sort of ischemia or any change in the color when the bowel first comes out. And there are some maneuvers that you can do to try and help with that. So my delivery room management of gastroschisis in particular is you want to tell the obstetric team to please leave a longer umbilical cord, at least 10 centimeters. Remember, in gastroschisis, the defect comes out to the right of the umbilical cord, so you should still have it. Covering the lesion is the most important thing. So placing the baby in what we call a bowel bag, but it's essentially just like a clear plastic bag that's sterile. You can also use cling film, saran wrap, and then some centers use sort of warm, sterile, normal saline, but ideally it's just to completely cover it. You want to do your normal NRP. So you're drying the baby, suction, stimulating. You're trying not to do too much bagging with positive pressure through the airway, because if you think about it, everything is just going to swell the bowel. So you try to minimize that, but obviously establishing the airway is more important than whether or not the bowel gets slightly more swollen. These babies will need IV access. They're going to need IV fluids. And then you would place a gastric sump or an NG, anything that can be attached to some suction to try and decompress that bowel. And these babies are going to need surgery. So you need to call the surgeons or transfer to a center that has the capability to surgically manage these babies. So here's gastroschisis. These are just two different ways that you can manage sort of covering the lesion. This on the right-hand side here is this bowel bag. And on the left-hand side, that baby has just been wrapped in saran wrap. And part of the reason why you're wrapping is because they lose a great amount. First of all, you want to keep it sterile because they are going to have to reinsert it into the abdomen. Secondly, it's you don't want to cause any injury to the bowel. And thirdly, there's a lot of insensible loss from that bowel wall. Babies can get dehydrated very, very quickly. And so the whole process of covering is to prevent those three things. So this is gastroschisis. You can see the bowel, obviously outside of the stomach. They often do look quite purple and hyperemic, and that's because the bowel has been exposed to the umbilical fluid, the amniotic fluid inside the abdomen. And then, so they think that it's caused by this involution of a right umbilical vein in utero, which creates this weak spot in the abdominal wall, and that is with pressure, the gastric contents come out. There's also some evidence or some association with teratogenic exposures and causing vasoconstriction, and then there are also other genetic influences. These are really diagnosed prenatal. They can be diagnosed prenatally. They also sometimes are postnatal if they didn't have the capacity for ultrasound. And again, with that exposure, you get elevated alpha-fetoprotein in the mothers. The prenatal presentation, often you can get oligohydramnios, fetal growth restriction. They do often come out slightly premature. There is stress at the delivery, some meconium-stained fluid, and they have associated intestinal atresias as well, which then can lead to polyhydramnios. In terms of delivery, it hasn't been shown that C-sections are advantageous over standard vaginal delivery, but except in the case where the liver is involved, and then you may get, it's beneficial to have the C-section to minimize chances of injury to the liver and hemorrhaging. Just to differentiate between gastroschisis and omphalocele, and omphalocele is where the contents of the bowel are inside the umbilical cord. And this is thought to happen between the sort of 6th and 10th week of development, where the bowel is supposed to enter the umbilical cord and then come back out again. And that's failure for it to come back into the abdomen is what causes omphaloceles. I don't think we have time to go over the differences between the two, so I'm just going to flip to the end to see if anyone has any questions. The way and then talk about the closure of gastroschisis. There's either primary closure for very small lesions that can be pushed in, and then also a silo, which is a gradual reduction over time. You put the bowel into this plastic bag and they reduce it over time, and it kind of goes back into the abdomen, and then they're able to close it using the umbilical cord that they saved from the delivery. Does anyone have any questions generally? I'm just cognizant of the time. For me, managing all congenital anomalies kind of go through the same thing. You always want the history, the exam. You have to think about, how can I stabilize this baby now? Where do I need to be for definitive management? And what's this family going to need in terms of long-term rehabilitation and support? And communication, like their families just really need to know what's going on, what's coming next, and what to expect for their child. So family counseling is a major part of it. Thank you, guys. I think we're due to go back pretty soon. If you do have any other questions, you can put it into the chat to me directly, or my email was further up in the chat. If you have any other questions about neonatology, even though it's not related to congenital anomalies.
Thank you very much for those really illustrative cases. There's so many different congenital anomalies, but some of these creep up on you. Some of them are right there, and you're like, what do we do with them right now? And I think those were terrific cases to illustrate a lot of the management principles and the importance of history as well.
Perfect. Thank you.
All right. I think we're going to get back together here as a group. Looks like we're all back together. Our numbers have dwindled some, but I'm just going to mention that I've been keeping track of the numbers throughout the morning or throughout the session. We got as high at one point as 32 individuals on all at once. And I think probably we've had north of 40 different individuals participating at some point throughout today. And so we want to use our last little bit of time together just for some brief discussion, a little bit of planning, but I'm going to open it up to Dr. Lewis Roberts, who's our president of Africa Partners Medical, see if he has any comments that he wants to make to the group.
Thanks very much, Jay. And I'd just like to thank all the faculty for taking the time to be here and to present. It's my experience that you never know what an individual will learn from that you share that will make a substantial difference in their practice and in their colleagues and most importantly of all for their patients. And as many of you are aware, rallying cry, for want of a better word, is that desire that we have to reduce needless illness and death in Africa. I want to really thank Jay for his commitment to continuing to advance knowledge and provide information so that people can build skills in Africa, and the work that he does outside of these programs to make sure that we're continuing to provide the very best care, the very best training to our colleagues. So just wanted to really recognize the faculty and also thank the attendees. Really encourage you to tell others about these programs, to reach out to us if you have questions, and we're eager and willing to help you in any way we can. Thanks very much.
Thanks so much, Dr. Roberts. I also want to echo the sincere appreciation to all the faculty today. I know that we had some sessions run a little long and we weren't able to get to the very final session in the nurses breakout by Terry Riffle, but she's been a longtime supporter and participant, and we can certainly schedule her presentation at a different time. as well. I also just appreciate the people that are showing up, faculty that have participated in the past but are here today, both to support and bring a dialogue along. It's really about the relationships, and as Dr. Roberts mentioned, and we also heard from our very first presenter, we never really know what's going to come out of these things. There might be one piece of information that you can directly apply to a patient. There might be some form of inspiration that helps you get involved in other ways. That's really what this is all about, in long-term commitment to each other, but ultimately to the patients that we have the privilege to serve. We're looking ahead now for future educational opportunities. We would really love to be back together in person, and we are still planning, Lord willing, on an in-person conference in Ghana in March of 2022, sent out some of those dates. We're going to be convening our planning committee toward the end of this month and really start working in earnest towards pulling together faculty. There have been polls in the past to find out what types of information you'd most like to hear about, what would be most useful for you. Some of today's programming was based off of that. I have a repository of that as well, and we'll continue to solicit information to see how we can put together programs that meet people's needs. In the last few minutes here, if anyone on this webinar wants to kind of unmute yourself and just share things that you think might be helpful to our group as we plan future sessions, both virtual and in person, we'd really love to hear from you. What works well, what isn't working so well, what kind of content you'd like to be involved, what type of presenters you want to have involved. In recent years, we've engaged presenters of various different disciplines, and today was a good example of that as well. So I will be quiet for a little bit, and we hope to hear from some of you.
Hi, this is Fran. I have a question. Hi. So I'm actually working with University of Wisconsin Oshkosh campus, trying to implement a quality improvement project where, to kind of like get a global health course together for the nurse practitioner students over there. And one thing that I had plans of emailing Dr. Homie and later on about something in that, if you guys ever thought of having something like that, having students from here, maybe we arrange something with the hospitals in Ghana so students can go there, and then kind of like nursing student can go there and have a clinical experience. Do you guys have anything like that in mind, or for the future, or anything like that?
I think that's a terrific idea. Part of what we have been doing over time is, again, trying to help make connections. Dr. Robert is a master at that. And so seeing a need or a desire, in this case, having nursing students or nurse practitioner students here stateside learn more about global health and helping make those connections. I think there's a variety of ways to go about that. Some places already have well-established experiences and exchanges. I think from an Africa Partners standpoint, we would be happy to help kind of make some of the connections. We don't currently have plans to start an initiative like that, but several years ago, we didn't have plans to start the Young Doctors and then the Young Doctors and Nurses conferences, and somebody brought that forward, and then it became the plan. So bringing up these ideas is always helpful for what next steps are for us. And Louis, do you want to add anything?
Yes, thanks, Fran. I think it's a great idea. In the past, what we've done is we've had teams of medical students that wanted to have experiences, particularly in Ghana. And so we had, I think, 2 teams from the Mayo Clinic School of Medicine, where groups of medical students picked the topic. One topic was they wanted to study diabetes and hypertension in a sort of semi-urban population outside Kumasi. And we identified, a faculty member there. He actually now, I think, is either the dean or the provost, Professor Usu. And he actually coordinated the project for them. They did the project, came back, wrote it, and published it.
Okay.
A couple of years later, we had another group of students who were interested, particularly in women's health. And so we arranged for them to go, and they were particularly interested in increasing cervix cancer screening. So they did a project where they actually did pap smears. I think in the space of the 2 weeks or so they were there, they did pap smears on like 300 women.
Wow.
Because only about 5 to 10% of women in Ghana ever have a pap smear. So, so they did that, and then they had one of the pap smears read at the Kamfanochi Teaching Hospital in Kumasi, and one of them read here at Mayo, and then their publication was a comparative study. So they got to help out with clinical care, education, and then also with research.
Okay. All right. Well, thank you. So currently I'm just, because of COVID, the pandemic, I'm just working with the students for a virtual kind of project right now. And so it should be, I'm in the works, and then she'll probably be done with it by May of next year. But then in the future, the school is trying to work with me to see if in the future I have any plans of actually, having the student, coordinating something with the students going to Ghana or any other countries, which of course I told them I would love to take them to my country first. And so, so I wanted to, kind of like see what we have in mind. So I'll keep that in mind. And then if anything comes up, I'll just email Dr. Roberts and Dr. Homi and see where we can take from there. Thank you.
Thanks, great idea.
We're getting some good suggestions in the chat
Yes.
here. If those aren't able to see them, about medical entrepreneurship, quality improvement principles, mentorship program on publishing. Dr. Roberts has given a presentation in the past about some of the essentials of quality research projects, and I think we certainly could expand upon that, how to take it and get things disseminated in a meaningful fashion. And he just gave a couple of nice examples of how that's been done in the past.
That'd be something that would be interesting. We could, again, if we identify the group of people who wanted to spend, some time together, we could put together, maybe 2 or 3 hour workshop, or maybe even spread it out and do it an hour a week for several weeks. And that could be helpful. There are also programs that are virtual that you can attend, and we could send links for some of those programs. There's, for example, I think it's a workshop on clinical research that's put out by the National Institutes of Health here, but it's free, and many, I think hundreds, if not thousands of people around the world will take that course. So we can try to disseminate information on some of those opportunities.
Well, if any of you do have some other thoughts or ideas, don't hesitate to send them. When in the coming days, I'll try and distribute slides from today's presenters, reminders about the upcoming conference, requests for additional information or ideas, and we'll try and continue to keep people posted. It's as we plan an in-person conference, I know people's schedules are busy. We'll try and get information out far enough in advance. It's really helpful to know who is coming, what those people's interests are, because we can build things like this around there. We can build breakout sessions about research and publications. We even have ability to communicate with people in advance to say, come prepared with this kind of information and to optimize. But the further in advance that we can have ideas of who will be coming and what they're interested in, the more tailoring we can do. But we'll still have some of our mainstays, such as basic life support, newborn resuscitation, obstetrical emergencies that have always been part of the backbone of our training sessions, because we feel like that is information that can be very widely applicable while we are also trying to meet individual interests and individual needs. So any additional comments before we break for the day? All right, well, thanks so much. We appreciate the technical support from Lowell. Again, all of the presenters today and everyone that took time out of the weekend to be participants. And we hope that there's some learning that happened that can be applicable to your patients and patient care. Take care, be safe, be well, everyone, and we'll see you next time. Bye-bye.
Thank you.
So Lowell, we can stop the recording.